Der Ralf. Du, eine Frage. Ist richtig, dass die Leute noch nichts sehen im Moment?
Nein, die sehen noch nichts. Die sehen erst dann sozusagen, wenn der Countdown auf 0 ist.
Ja, perfekt. Weil gewisse Leute haben mich gefragt, ob es tatsächlich funktioniert oder so. Und gut, dann machen wir es so.
Gut, ja.
Und
dann du startest wieder dann, wenn du dich groß im Bild siehst, genau.
Ja, dann um Punkt 3 mache ich einfach mein
Greetings. Punkt 3, bist du genau um Punkt 3, spiele ich noch etwa eine halbe Minute sozusagen das Intro dort und dann, sobald du dich dann im Bild siehst, kannst du direkt loslegen. Also das ist immer, wenn ich will, ja.
Gut. Und die Leute, auch die Lecturer von gestern, die folgen mit dem Livestream wie alle anderen vom Publikum.
Wenn Sie sich angemeldet haben, verfolgen Sie mit dem Livestream, deswegen habe ich ja noch geschrieben, ja, Sie sollen dann, wenn Sie im Diskussionsraum sind, müssen Sie natürlich dort dann stumm schalten oder rausgehen, damit es nicht dann zu hören ist. So, das ist wie wenn du den Fernseher anhast und bist auf Zoom, dann hört man den Fernseher auch.
Kann es sein, dass vielleicht die Lecturer irgendwie nicht realisiert haben, dass sie sich sollen melden, oder weißt du das?
Ich weiß natürlich nicht, ob die sich angemeldet haben alle, aber ich muss jetzt ehrlich sagen, ich habe die E-Mails aus dem Ding genommen. Es haben sich alle angemeldet und haben heute den Reminder bekommen am Morgen, bis auf den Jason. Weil deswegen habe ich dort wegen der E-Mail nachgefragt, weil der war der einzige, den ich nicht gefunden habe im System.
Ja, okay, dann ich sage die zwei, wo mich gefragt haben.
Aber das ist auch nicht so schlimm, wenn die hier rein wollen, dann können sie auch hier rein. Aber grundsätzlich haben sie einen anderen Link bekommen, quasi den Dogflix-Link. Und das ist quasi der Stream über die Plattform. Da müssen Sie auch sich nicht einloggen oder irgendwie so einfach auf den Link klicken.
Okay, gut.
Bis aber nachher. Dieses Missverständnis gibt es manchmal, da hast du schon recht, dass sie die, ja.
Okay.
Alles klar, bis später. Tschüss.
Bis später. Dear colleagues, dear friends, welcome back to this 7th African Dermatopathology Conference. Yesterday we were quite unlucky and we had some streaming problem. So for me it's important to tell you my apologies for the technical problem of yesterday and for your understanding. Today the program should follow as normal with a normal streaming. What I can tell you is that the whole program of yesterday has been fully registered, and so you will have next week the possibility to see all the conferences, all the lectures of yesterday, inclusive the discussion that we had in the African Dermatopathology Society meeting. It was an intensive discussion about the society, about the future of some dermatopathological activities in the African continent. So today we have a more intensive program than yesterday. We have several lectures, and at the end we will have a discussion, a live discussion with the experts. So all the lecture of today, you can put your questions in the chat, and I will summarize your question in the chat and have a discussion with the experts. Also, this discussion will be on the video on demand to be followed next week. This is very important. So now, before we begin, I'd like to say thank you again to the organizers that intensively worked yesterday evening to make this program of today safe, and we should have also a reserve streaming platform if something could be wrong. Unfortunately, what happened yesterday, it was a global streaming problem, similar like the one who happened in WhatsApp a couple of days ago, and we had no chances to fix it within minutes or hour before the conference of yesterday would be finished. And thank you also to all lecturers for presenting all their topic. So we begin with the today program. Wayne Grayson from South Africa. He's a pathologist. He's a specialist in pathology with interest in dermatopathology and competence in dermatopathology. He will present diagnostic clue in cutaneous infectious disease. Thank you, Wayne, for your lecture.
Hello, everyone. My name is Wayne Grayson, and hello from sunny Johannesburg, South Africa. I'll be discussing diagnostic clues in cutaneous infectious diseases with you today. But before I continue, I'd like to extend a word of thanks to Dr. Beltranelli for the kind invitation to share my cases with you and to participate in this meeting. I'm sure it'll be a great success. I have no relevant disclosures to make. An image of the city where I was born and where I trained as a pathologist and where I continue to practice, and that's the city of gold, Johannesburg. Right, if we look at cutaneous infectious diseases, it really does comprise a vast clinical spectrum. It's important to remember that involvement of the skin can either be primary or secondary. It can be a primary skin infection or skin involvement secondary to systemic disease with spread to the skin. There's an ever-changing landscape. And it's important to remember that the skin manifestations can be due to the organism itself and the associated tissue response to the infection. And that's really what I'm going to discuss with you today. And having said that, it's also important to bear in mind that patients can also develop an inflammatory response to an infection elsewhere, manifesting with skin lesions, like erythema nodosum in a patient with, for example, a streptococcal pharyngeal infection, the tuberculosis in response to pulmonary tuberculosis, or erythema multiforme being precipitated by genital herpes simplex, etc. And this is such an example of where it's a secondary finding in the skin. So this little one was barely a month old and presented with these multiple necrotic papules, which on biopsy showed crusted, wedge-shaped areas of necrosis with vasculitic changes at the base and some granulomatous inflammation, looking very much like papillonecrotic tuberculosis. Now, why on earth would a neonate develop papillonecrotic tuberculosis? Well, I then asked the dermatologist to check the deltoid area of little one's arm and see if a BCG vaccine had been administered. And indeed, that's the exact site of the BCG vaccination, which shows a rip-roaring granulomatous response. And this is an example of BCG-itis, or response to the BCG vaccine precipitating papillonecrotic tuberculin. It's a way of illustrating tuberculin. Right, so the overview of my lecture today, I'm going to first dwell on helpful and better known clues. Some of them will be very familiar to you and be mere revision. And then I'm going to go on to some uncommon or unexpected histological reaction patterns to infections, and then some concluding comments. So let's look at the helpful and better known clues. So what about neutrophils within a parakeratotic stratum corneum? Well, this is such an example I saw just a week ago of a parakeratotic focus with neutrophils in there. And that's a clue, that's a so-called sandwich sign described by Ackerman. And that should be a reminder of a possible superficial fungal infection. Yeah, it's extremely subtle, as we see there in this field here. And this is an example of tinea incognito. So that's an important clue that we see in everyday practice. As do we see neutrophil-rich subepidermal pustules. And the prototype there would, of course, be bullous impetigo. What about a basophilic hue to the stratum corneum? This is a high magnification view of a biopsy that looked otherwise normal, apart from the presence of mild hyperkeratosis, and on close inspection, this vague basophilia. But the astute dermatologist had made a clinical diagnosis, and that made me look a little closer, because on the gram staining, it's clearly full of these bacillary organisms. And it's an example of erythrasma due to Corynebacterium minutissimum. This biopsy was taken from the foot and from a patient with suspected plantar warts. And you'll appreciate that there's a slight depression in the thickened stratum corneum. And on closer inspection, there's a vague basophilia once again to this. And it's because of the presence of these large numbers of organisms, which you might think are tinea species, but in fact they're not. They're gram-positive organisms, likely Chytococcus sedentarius, or one of those sorts of organisms that's responsible for this condition, which is known as pitted keratolysis. So those are basophilic clues. What about the so-called pigtail sign? This lady presented with papules on the upper thighs and buttock area, and one of the biopsies I thought looked relatively non-specific on initial inspection, apart from hyperkeratosis and parakeratosis. But something caught my eye at the top, and I thought it was just a little peeled off piece of stratum corneum, until I looked really closely under oil and recognized it from something that I'd seen at another dermatopathology meeting. And those are clearly not bits of keratin. It's a so-called pigtail sign, and they're actually eggshell casings. And a repeat biopsy was then done, and it confirmed the presence of Sarcoptes scabiei infestation. This is so-called scabies with pigtail sign. What about intranuclear inclusions? Well, we're all familiar with these, the typical inclusions that we see of Cowdery type in the setting of a herpes infection like herpes simplex or herpes zoster. This is an example of herpes zoster with such inclusions. But intranuclear inclusions are also seen in other viral infections like cytomegalovirus. And sometimes we see both viruses present in the same specimen, like this biopsy of a genital and perianal ulcer in an HIV patient with both herpes simplex and CMV infection. What about multinucleate epithelial cells? This case, the multinucleate giant cells involving that hair follicle, which is partly necrotic. And this biopsy is from that same gentleman that I showed a short while ago with the lesions on his forehead. This is, in fact, varicella zoster virus with multinucleation of follicular keratinocytes. This case is interesting in that it shows on the left-hand panel changes that you might see in a viral exanthem. But if you look very carefully at the hair follicle, there's some multinucleate cells present there too. And this was a case of proven measles. So what about reticular degeneration of the epidermis with associated blistering? It's a very distinctive appearance, and it's the first case I've seen like this. There's blistering and these reticulated downgrowths and strands of epithelium with a lot of intercellular edema. And something caught my eye on high magnification. There are these intracytoplasmic eosinophilic inclusions. There's another one, all there. And they stained with Lendrum floxine tartazine. This is in the case of parapox virus infection, the patient who had a whole number of animals on the small holding that she resided in outside of Johannesburg. We were never able to prove which animal had infected her, but on electron microscopy, clear evidence of parapox virus infection. So it's something in the group of Milker's nodule or something in that vein. What about profound subepidermal edema? Well, we all know that this is something that one might see in cases of bullous erysipelas, but just bear in mind that cutaneous anthrax also causes very marked subepidermal edema. Fortunately, the organisms are enormous, so they're easily visualized on gram staining. What about intraepidermal neutrophils in association with dermal plasmacytosis? Well, this is a case of a biopsy from the palm of a hand of a young man who was suspected of having pustular psoriasis. And you might think, well, there are certainly pustules there, intraepidermal spongiform pustules reminiscent of spongiform pustules of Gauguin, but there's complete absence of the stratum corneum, which would be rather unusual for psoriasis. There we see the neutrophils. But he had a rather busy-looking dermis with many inflammatory cells, a hint of interface dermatitis, numerous plasma cells around, and that made me concerned because of the involvement of the palms and soles. And I did a Wharton Starry stain and was crawling with organisms which have proven to be Treponema pallidum spirochetes. So that's an example of pustular secondary syphilis. What about intracellular organisms contained within vacuoles? Well, there's a broad differential for this, and the prototype there would, of course, be this infection, which we're familiar with. You can see the vacuolated cells containing globi of acid-fast bacilli and the Mycobacterium leprae bacilli. And this is an example of Lepromatous leprosy. But other infections can also present with intracellular organisms in vacuoles. At this example, there's a dense plasmacellular infiltrate and a histiocytic infiltrate containing cells which, on close inspection, clearly contain microorganisms. With the eye of faith under oil immersion, one could almost appreciate kinetoplasts. So it's an example of Leishmania infection. But intracellular organisms are also seen in this particular condition. This biopsy was of a genital ulcer in a young woman, and we can see similar histology, except they're more safety pin-like bacilli, with a distinctive appearance of granuloma inguinale. Other causes of intracellular organisms would be emergomycosis, and histoplasma capsulatum can look identical to this too. So a broad spectrum of intracellular organisms is seen. What about necrosis en masse of the pilosebaceous follicles? Here we see a hair follicle which is almost complete loss of cellular detail because of necrosis, which also involves the sebaceous component. And this is a case of necrosis en masse in the setting of a herpes infection, in this instance varicella zoster virus infection. What about extensive ulceration with epidermal and dermal necrosis? What can that be a clue to? Well, the first condition that comes to mind is something like necrotizing fasciitis, but you can see necrosis, pandermal and epidermal necrosis for other causes. So, like this example, an incisional biopsy of a large ulcer with complete loss of cellular detail. In the more viable areas, we can see a neutrophilic response and this almost coagulative looking necrosis of the dermis extending into the subcutaneous compartment, where thrombi were also seen. And on staining with a panel of infective organ markers, we found strong staining with Ziehl-Neelsen, and we then correlated with clinically, found that the gentleman had been traveling up in Africa and swum in rivers and contracted a Veruli ulcer, which was proven by PCR to be Mycobacterium ulcerans. This was a biopsy from a gentleman on a chemotherapy for acute myeloid leukemia, and he developed necrotic eschar-like skin lesions, and there's a complete loss of all cellular detail because of necrosis of the epidermis and dermis, and what looks like thrombi occluding the dermal vessels. But on closer inspection, those aren't strands of fibrin in the vessels. They're in fact thrombi containing vast tangled masses of infective organisms, in this case fungal hyphae, stained with pus and Gros-Kot. And this is an example of hyelohyphomycosis, or one of the angioinvasive deep fungal infections, in this case acromonium, causing that picture. What about folliculocentric neutrophilic infiltrates? Well, the prototypic example here is suppurative folliculitis due to bacterial etiology, as seen here. But just bear in mind that neutrophilic infiltrates can be precipitated by other infections, including this one, which you see fairly commonly. And we can appreciate the background, small yeasts present there under oil immersion, the clinical picture and histological findings here diagnostic of Malassezia Pterosporum folliculitis. What about suppurative granulomas? One automatically thinks of an invasive fungal infection when one thinks of suppurative granulomas. And this is a prototype of that, and that's sporotrichosis with a typical asteroid body of Sporothrix visible there. That can be seen in other invasive fungal infections too. But just bear in mind, suppurative granulomas are also a feature of atypical mycobacterial infections, and particularly fish tank granuloma due to Mycobacterium marinum infection. This case caught me out a few years ago because it seemed like a large suppurative granuloma. It was only on deeper tissue sections that I realized that it was all centered around a hair follicle, which wasn't visible in the initial sections. So this was a case of HIV-associated furunculosis with intradermal rupture, inciting a suppurative granulomatous response mimicking an invasive fungal infection. If one sees a pandermal granulomatous or histiocytic to infiltrate with proclivity for the neurovascular bundles, there's really only one differential diagnosis to consider. And here's such a case where one can see these sausage-like infiltrate following the neurovascular bundles with a histiocytic, vaguely granulomatous appearance to the infiltrate, showing positive staining on Wade fight. And it's an example of borderline lepromatous leprosy. So leprosy is the very typical histological appearance of clue there. What about extracellular granular material? If one sees granular amphiphilic extracellular material, it's easily overlooked and can be mistaken as fibrin. But if you see a very vascular background with neutrophilic debris, one must think of this infection. That's a Bartonella infection, and it's in fact bacillary angiomatosis. So if you practice in an environment with a high prevalence of HIV, one must have a high index of suspicion for this perfectly treatable but potentially lethal bacterial infection. If you see large granular colonies of infective organisms, there is also really only one differential, and that's a mycetoma. In this case, it's a fungal mycetoma or eumycetoma, but actinomycetic mycetomas also produce large granular colonies of infective organisms. The opposite of that are these small flocculent colonies of organisms in large spaces surrounded by neutrophils. And here we see a typical example of such an infection. It's a neutrophilic abscess with a clear space with flocculent bacterial material in it, staining with Ziehl-Neelsen. That's a typical picture of Mycobacterium chelonia infection. Now, you might think this is an identical case, but it isn't. In fact, this is a case of nocardia infection looking almost identical. So culture and clinical pathological correlation would be very important there. And then finally, what about only seeing a fibroblastic response in the dermis after doing initial sections? And this is a case I saw just a week ago where multiple leg sections only declared this little central area here, fibroblastic proliferation. But having seen it once before and knowing the clinical picture of multiple tiny papules, proceeded to cut deeper, and it declared a little lesion of molluscum contagiosum. So that's a useful clue to tell you to cut deeper into the block. So I want to move away now to the uncommon and unexpected reaction patterns. They're a potential source of misinterpretation and diagnostic error. There's a broad histological spectrum, but it's important to remember that in some patients, there can be a negligible absent inflammatory response when they're profoundly immunosuppressed. Like this patient who clearly has extensive skin lesions, HIV positive, but with a very, very low CD4 count. And this is the biopsy of one of those lesions. And I was consulted by a colleague because the biopsy seemingly showed no pathology whatsoever. But it's not true. If you look very carefully, the dermis looks a little busy. There's some flocculent material between the collagen bundles and a few inflammatory cells lurking around. And on very careful scrutiny, under oil immersion, there's some organisms, both extracellularly and intracellularly. And that's an example of AIDS-associated hemogomycosis with virtually no host response to the infection. In a similar vein, this case kindly shared with me by Philip McKee, and this, I believe, is a solid organ transplant recipient who developed skin lesion. The biopsy also looked normal on cursory inspection. It's only when one looked at the epidermis that something caught one eye there in those keratinocytes. And then here in this vascular endothelial cell, a very typical morphological appearance of a bradyzoite of Toxoplasma gondii infection, a really rare infection to see in the skin, but it just shows how subtle clues can be easily overlooked if you don't approach these cases meticulously and carefully. So let's look at the reaction patterns to infection. I'm going to cover all of these systematically. So let's look at specific inflammatory infiltrates where they can be eosinophilic or neutrophil rich. Langerhans hyperplasia can occur. This can be a granulomatous response, even a pseudolymphomatous response, or even a pseudotumoral spindle cell response. The epidermal responses include pseudoepitheliomatous hyperplasia and hyperkeratosis. And then I'm going to end off with some unusual forms of necrosis. So let's just look at infections where you expect to see eosinophils. And the prototype would be any sort of infestation, in this case, scabies. And in this paper, something like 88% of the patients had a significant contingent of eosinophils in the dermis. This is a patient who came to South Africa for treatment, had multiple lesions on the trunk and very itchy. And this is a biopsy, nice deep punch biopsy, and it showed eosinophilic paniculitis, the densely infiltrated eosinophils. And on careful scrutiny, there were definite larvae present in the subcompartment, and clinical pathologically this was felt to be onchocerciasis with eosinophilic paniculitis. Another infestation here, this patient with migratory nodules, after having consumed, or admitting later to confessing to consuming freshwater fish, we can see a flame figure formation in the dermal compartment with many eosinophils, and then a tract where something had clearly moved through and left destruction in its wake, but no clear organism visible. But because of the history, this fitted with mastostomiasis. Now, when we think in terms of eosinophils, we really very seldom think of fungal infections having an infiltrated eosinophils, but there is one exception, and that's this condition with large fungal hyphae inciting an eosinophilic response, and that is basidiobulomycosis. Now, I was caught out by this case where a colleague consulted me because of a lump or mass removed from the patient's foot, and it showed eosinophils with flame figures and clear organisms which looked fairly large, with retrospectively the hyphae looked a little too delicate for basidiobulomycosis, but on PCR we found to be fusarium organisms, and this is a case of hylohyphomycosis mimicking entomophthalmomycosis, and I'm not aware of any other cases having been reported in the literature with an eosinophilic response. Other settings where eosinophils are an unexpected finding, this biopsy of an ulcer, a genital ulcer, many eosinophils. If you look very carefully, there's some remnants of HSV, degenerate HSV infected keratinocytes, and it's highlighted in this paper which deals with the spectrum of herpes simplex, and eosinophils are a well-documented part of that potential spectrum, as is this condition, in which eosinophils are a very unexpected finding. This patient had a rash which affected the palms and soles and was in fact proven to have syphilis, but with eosinophils in the infiltrate, which one sees rather uncommonly. So just bear in mind that syphilis can also have eosinophils. What about neutrophils? Well, we all know that pyogenic infections incite a neutrophilic response, and this dermal abscess shows staphylococcal organisms present in the abscess. So you expect that. But when don't you expect to see neutrophils? Well, this case, HIV-positive patient with very large numbers of widespread skin lesions. He was gravely ill, and this is his biopsy with subepidermal neutrophils forming these microabscesses that look very reminiscent of those seen in dermatitis herpetiformis. And with HIV-positive patients, one knows one must do a comprehensive panel of stains for infective organisms. And Ziel-Nielsen showed that the biopsy was teeming with acid-fast bacilli, and it's a case of disseminated cutaneous tuberculosis in AIDS. The patient had tuberculous meningitis and had passed away shortly after this biopsy was taken. Just bear in mind that Cryptococcus can also cause a neutrophilic infiltrate unexpectedly, and this is a case report exemplifying that, where the neutrophils completely obscured the background infiltrate of fungi in the dermis. So that really is a potential pitfall. What about Langerhans cell hyperplasia? The prototypic condition that does this is scabies, and there are many reported examples in the literature where pediatric cases of scabies have been associated with such severe Langerhans cell hyperplasia that a diagnosis of Langerhans cell histiocytosis has been erroneously rendered. So if you don't look very carefully at the overlying epidermis and notice that there's scabies organisms there, it's very easy to be caught out. And it's also been described in molluscum contagiosum infection, which I found rather interesting. Now, what about necrotizing granulomatous inflammation? Well, we all know this condition with necrotizing granulomas, caseous necrosis. Now, in this patient, the Ziel-Nielsen stain was negative, but culture and PCR proved the presence of Mycobacterium tuberculosis. So we expect to see necrotizing granulomas in lupus vulgaris, but when don't we expect to see necrotizing granulomas? Well, this was a lady who presented with this ulcer on the upper arm, and on the biopsy, we see necrotizing granulomatous inflammation, which looks amazingly tuberculosis-like. It's only on careful inspection of the histiocytes that one can see that there are intracellular organisms. And they're actually Leishmania organisms confirmed on electron microscopy. We see the kinetoplast, and this is a lady of Greek descent who had returned to the Mediterranean on vacation and contracted the infection there. What about pseudolymphomatous reactions? Well, look at this image. It really looks like a non-Hodgkin lymphoma, but in fact, it's a response to herpes. And you can see some of the herpes-infected keratinocytes there from the ulcer edge, but it's very easily overlooked if there's extensive ulceration and you're so taken in by the density of the infiltrate. And this was highlighted in this nice 2006 paper focusing on the pseudolymphomatous nature of some herpetic infections. In a similar vein, a number of infections can cause a proliferation of CD30 positive cells, and they can really be quite atypical and mimic CD30 lymphoproliferative disorder. And this table highlights that list and includes parapox virus infection. Herpes is there again, and then molluscum contagiosum. And here's an example of my own where the molluscum was almost overlooked in the initial sections and declared itself on deeper sections. But the infiltrate surrounding the molluscum showed a very dense population of CD30 positive cells looking very much like something like inflammatory papulosis. So just bear in mind, that's a real pitfall. What about spindle cell proliferations? This was a biopsy of a mass lesion, and it certainly looks like one's dealing with some sort of spindle cell sarcoma. The cells look relatively bland. They express CD68, and because of the setting of immune compromise, a Ziehl-Nielsen stain was done, which showed acid-fast organisms, and that's a mycobacterial spindle cell pseudotumor. Just bear in mind that pseudotumors have also been described in other infections, including Cryptococcus infection. Pseudoepitheliomatous hyperplasia, we know, is a hallmark of deep fungal infections, and this is an example of blastomycosis with pseudoepitheliomatous hyperplasia. When don't we expect to see it? Well, I'm going to get to that point shortly, but this is an extreme case of pseudoepitheliomatous hyperplasia that I saw a few years ago, where it really looks like a squamous cell carcinoma. It's a 27-year-old lady with HIV, and we can see attempted transepithelial elimination of vast numbers of organisms stained on PAS. And this is an example of hemochromycosis with really profound pseudoepitheliomatous hyperplasia. When we don't expect to see it, those infections like bacillary angiomatosis, so it can be so marked that one overlooks the underlying treatable bacterial infection, which would be a travesty. So just bear in mind that there is a broader spectrum. And these two excellent review articles focus on all the causes of pseudoepitheliomatous hyperplasia in the skin, and I can really recommend them. So what about hyperkeratosis? Well, we all expect it in viral warts, verruca vulgaris and verruca plantar. When don't we expect it? Well, in this setting, this is a patient with HIV/AIDS who presented with hyperkeratotic skin lesions. On close inspection, there was obvious varicella zoster virus infection, but this is an example of hyperkeratotic herpes zoster. So immunocompromised patients can develop these hyperkeratotic lesions in response to zoster. What about unusual forms of necrosis? Well, this was a diabetic patient in his 40s who underwent debridement of this lesion on the scalp, and there's extensive ulceration and necrosis, particularly fat necrosis with this basophilic hue looking remarkably like pancreatic fat necrosis, as we see there. But something catches one's eye there, and we come back to that. In other fields, they're almost crystalline structures within the necrotic adipocytes, looking very much like gouty paniculitis. But again, something catches one's eye as a very important diagnostic clue. And in fact, closer inspection of the vessels revealed clear angioinvasion by these broad fungi. And that's an example of mucormycosis mimicking pancreatic paniculitis and gouty paniculitis. And there have been a number of reports of this phenomenon in the recent literature, and it is a real pitfall. So just some concluding remarks. Well, one must be aware of the wide spectrum of reactions in response to infective organisms. If you're not aware of them, it's very easy to make an erroneous diagnosis. It's important to always do a baseline panel of histochemical stains for infective organisms, particularly when you're dealing with HIV/AIDS patients or organ transplant recipients or other immunocompromised patients on chemotherapy. Never underestimate the importance of a travel history or an occupational history in looking at specimens. Dermatologists don't biopsy fresh air. So if you see a biopsy that looks normal or doesn't show any pathology, you need to really ask yourself, well, why would they biopsy fresh air? Well, they wouldn't. So you must look for changes, look harder, because the clues can be very subtle. Just think of that toxoplasma case I showed you a short while ago. So it requires systematic scrutiny of the biopsy, and it reduces the risk of overlooking those clues. So look harder, and then very importantly, cut deeper. I think those are two important messages I'd like to leave with you. And we always say this, but clinical pathological correlation is really of paramount importance. So you need to know the clinical context of the case, and that serves as a beacon as to where we as pathologists need to focus on in any given biopsy. And missing subtle clues can have grave consequences, particularly if a patient's immunocompromised and they have a treatable opportunistic infection. We really don't want to miss cases like that. And finally, I think it's true to say that serial sections in the telephone are skin pathologists' best friends. So thank you for your attention. I'm going to end there. I'll be happy to take any questions during the Q&A session. Thank you, and thank you for the invitation to speak, and enjoy the rest of the meeting. Thank you. Goodbye.
Thank you very much, Wayne, for this beautiful presentation. You are really an expert in these diseases that are quite rare. Some of them I've never seen. I'm not sure that I will encounter them in my working latitude, but of course, where you work, it's of relevance, and a lot of people assisting and looking at this presentation work in Africa, and so it's fantastic to have your experience. I can tell you that we have more than 310 registered attendees, and this is fantastic. I'm very happy to have so many people interested in dermatopathology in Africa. So please write in the chat your questions. At the moment, I've seen no questions, so I'm collecting the question for 6 o'clock, for 7 o'clock, where we will discuss them live with the expert. So the next expert is Fuad Temam from Ethiopia. He will speak about life of Kaposi sarcoma.
Good afternoon, everyone. Today, my talk will be focusing on lives of Kaposi sarcoma. Kaposi sarcoma has a different stage of development, like many of the lesions. Here is the objective of my presentation. By the end of this session, all the participants will be able to describe the various stages of Kaposi sarcoma, and the enabling objectives are listing of histopathologic features of early, fully developed, late stage of Kaposi sarcoma, and at the end, establishing the clinical pathologic correlation. I will follow this outline. I will say a few words about the introduction, and I'll go through the clinical manifestations, then the histopathology findings of the early, fully developed, and late stages of Kaposi sarcoma, and the histopathological differential diagnosis with the immunohistochemistry, and at the end, the summary of the session. So as an introduction, Kaposi sarcoma is a multifocal tumor of endothelial cell origin. It was first described by Maurice Kaposi in 1872. Kaposi described 5 patients with Kaposi sarcoma, and this condition has a stage-dependent characteristics of histopathology. The development of Kaposi sarcoma is invariably linked with the human herpes virus 8 infection. The condition occurs in 4 different clinical variants. Despite of the presumed viral pathogenesis, Kaposi sarcoma responds well to chemotherapy and radiation therapy. So here we look at the 4 clinical manifestations of Kaposi sarcoma. The first one, the classic form of Kaposi sarcoma, the African endemic Kaposi sarcoma, the immunosuppressive therapy associated Kaposi sarcoma, and last, the AIDS associated Kaposi sarcoma. So the classic Kaposi sarcoma, the classic form of Kaposi sarcoma, usually is seen in a patients that are mostly Caucasian, male in their 60s. Patients have commonly a Mediterranean or a Jewish background, and the annual incidence of the classic Kaposi sarcoma shows a geographic variation. For example, it's about 0.14 per million in the UK, whereas 10.5 per million in Italy. And there's a gender predilection for classic Kaposi sarcoma. A male to female ratio is 3:1, and usually it runs a benign course. Clinically, this form of Kaposi sarcoma starts as a bluish red macules on the lower extremities, and this is most commonly seen on fair-skinned individuals, but in dark-skinned individuals, it's rather a grayish, dark, pigmented macules on lower extremities. So the lesion progresses gradually and develop into a firm papule. Subsequently, with the coalition of those papules, plaques will be formed. Subsequently, nodules will also develop. So when you come to the African endemic Kaposi sarcoma, Central Africa reported increased frequency of Kaposi sarcoma, and this happened actually many decades before the outbreaks of acquired immunodeficiency syndrome. Some of the sub-Saharan countries have reported 10% of all malignancies. Male to female ratio ranging 3:1 in children, and this ratio was even pretty much significant, up to 18:1 in adults. The age of onset of the African endemic Kaposi sarcoma is lower compared to that of the classic Kaposi sarcoma, was 35 to 39 years for male and 25 to 39 years for female. And the clinical presentation is in form of nodular, florid, infiltrative, and lymphadenopathic, and the presence of lymphadenopathy affecting commonly children, and it runs a fulminant course of a condition. The third clinical variant of Kaposi sarcoma is the immunosuppressive therapy associated form. There was a high incidence of Kaposi sarcoma described in 1970s in organ transplant recipients. The increase was significant in this group of patients, up to 500-fold increase as compared to controls. And the immunosuppressive therapy associated with Kaposi sarcoma was observed mostly in renal allograft recipients, and it can occur as early as 1 month and as late as 10 years following the organ transplantation and subsequent immunosuppression therapy. I think it's important to note that the type and the dose of the immunosuppressive drug is critical. For example, the cyclosporine has a higher associated risk in causing the immunosuppressive therapy associated with Kaposi sarcoma than the glucocorticoids or other immunosuppressive drugs like azathioprine. Like in many clinical forms of Kaposi sarcoma, it has a male preponderance, and the male to female ratio is 3:1. Last but not least, there is the AIDS-associated Kaposi sarcoma, and the AIDS-associated Kaposi sarcoma was an AIDS-defining illness during the first decade of AIDS pandemic. But Kaposi sarcoma, which is AIDS-associated, is still the most frequent AIDS-associated tumor And this form of Kaposi sarcoma has a rapid course and a rapid multifocal dissemination. Clinically, the AIDS-associated Kaposi sarcoma presents mainly on the face. The early lesions appear on the nose, the eyelid, and the ear. And the oral mucosa is frequently involved and represents the initial site in about 10 to 15% of all cases of Kaposi sarcoma that are associated with AIDS. The extracutaneous sites of the AIDS-associated Kaposi sarcoma are the lymph nodes and the gastrointestinal tracts, as well as the lungs. The AIDS-associated Kaposi sarcoma has a predilection for the stomach and duodenum, and it can cause bleeding and ileus. This slide is showing a multiple violaceous and dusky red erythematous plaques over the proximal chest, and some are in form of nodules. And this patient is an HIV infected male having sex with male, pointing out the high risk groups of developing the acquired immunodeficiency syndrome. This is one of my patients, AIDS-associated Kaposi sarcoma, presented with multiple violaceous nodules and plaque lesions over the lower leg. This slide shows the age-standardized incidence rates of Kaposi sarcoma per 100,000, which was published in Nature Reviews in 2019. If we can take Ethiopia, my country, as example here, the reported age-standardized incidence rates of Kaposi sarcoma per 100,000 was 4 to 22. And the next slide shows the correlation of the Kaposi sarcoma herpes virus seroprevalence rate, which was published in the same study and time, 2019. For my country, Ethiopia, it was indicating about 21 to 40. Now we will move on to the histopathological features of Kaposi sarcoma at its different developmental stages. So the early stage of Kaposi sarcoma, which is the patch stage, histopathologically, it shows a widely dilated and jagged newly formed vessels. And these widely dilated vascular channels, they are lined by flat endothelial cells. The changes are mostly found throughout the dermis, but at the early stage, they are mainly confined to the upper half of the dermis, which gives the appearance of a busy dermis. And these newly formed vascular channels, they are situated around the pre-existing oval to round vessels. The infiltrates around those newly formed vessels are composed of lymphocytes and plasma cells. In addition, at the early or patch stage of Kaposi sarcoma, individual spindle cells are discernible between the bundles of collagens of the connective tissue. This slide shows the early patch stage of Kaposi sarcoma in black and white. As you can see, there are increased number of widely dilated irregularly shaped vascular structures with jagged outline, mainly confined to the upper half of the dermis, and those inflammatory cell infiltrates around those widely dilated vascular channels are lymphocytes and plasma cells. Higher magnification is showing the bizarre thin-walled newly formed vessels, again lined by the flat endothelial cells at the early or patch stage of Kaposi sarcoma. This picture has been taken from YNA that was published back in 2008. As you can see, this slide is clearly showing the protruding of those newly formed vessels into a larger vascular space, regarded as a promontory sign. Here again, hematoxylin used in staining, showing as a multiple widely dilated, angulated vascular structures lined by flat endothelial cells. And those newly formed vascular structures, some of them, they are really dissecting the bundles of collagen along with the inflammatory cell infiltrates. The high power, again, showing this bizarre shaped, widely dilated, newly formed vascular structures between bundles of collagens, and the lining of those mostly flat, but in some of those newly formed vascular spaces, you see some of the plump endothelial cells. This slide is showing the cytomorphology of the infiltrates associated with the Kaposi sarcoma. These infiltrates are the patchy, moderately dense infiltrates around the newly formed vessels, and they are composed of plasma cells and lymphocytes. And we move on to the histopathology characteristics of a fully developed or a plaque lesion of Kaposi sarcoma. This form is characterized histopathologically by markedly dilated, jagged, thin-walled vascular spaces, and the lining of these newly formed vascular spaces is with thin or sometimes slightly atypical endothelial cells. And there is an associated moderately dense plasma cells and lymphocytes. In addition, we do observe extravasated red blood cells and siderophages. Some of the spindle cells are arranged as solitary units and in some aggregations throughout the dermis. We may be able to see one or two more of the erythrocytes within the slit-like spaces between the spindle cells. This slide shows, in addition to the irregularly shaped vascular structures, numerous tiny spaces lined by endothelial cells. Again, we see numerous tiny vascular spaces and proliferation of spindle cells in the middle of the collagen bundles, most commonly containing one or two red blood cells. This picture is taken again from the same publication by YT and representing the plaque stage of Kaposi's sarcoma. We see many intra and extracellular eosinophilic Hewlett globules, and the arrows are indicating the paranuclear vacuoles. Coming to the late stage of Kaposi sarcoma, or the nodular form of Kaposi sarcoma, histopathologically, this form of Kaposi sarcoma is characterized by large aggregates of spindle cells throughout the dermis, and the proliferation of the spindle cells are seen in interlacing fascicles. One or two erythrocytes can be discerned in the slits between the spindle cells. We also observe the extravasated erythrocytes and siderophages in the stroma. And they are widely dilated vessels, contiguous to one another. And probably a particular finding in the late or nodular stage of Kaposi sarcoma is the presence of crusts due to erosion, and we can also observe the ulceration, and mostly we do observe the granulation tissue above the aggregations of those spindle cells. This slide shows nodules of spindle cells that are arranged in interweaving fascicles throughout the dermis, and it has a pushing up effect which made the epidermis become flattish, thinner. High power is showing several dense collections of slightly atypical spindle cells. Some of them are in mitosis. Another example, a histopathology example of a nodular Kaposi sarcoma. Here it shows at lower magnification a well-defined dermal nodule. Higher magnification showed proliferation of numerous spindle cells arranged in a haphazard fashion, and the erythrocytes within the newly formed small vessels, as well as the slit-like spaces formed by those spindle cells. Hewlett globules, are they useful in making a diagnosis of Kaposi sarcoma? So this was published in 1991, the Hewlett globules in Kaposi sarcoma, a light microscopic and immunohistochemical study by Fukunaga and Silverberg. So Hewlett globules, they are not specific for Kaposi sarcoma, and they are said to be most likely digested erythrocytes. In this study, Hewlett globules have been found in 51 out of 54 Kaposi sarcoma lesions, constituting for 94.4%. But those Hewlett globules were also present in 5 out of 6 angiosarcomas and in 2 out of 10 pyogenic granulomas or lobular capillary hemangiomas, and in 7 out of 32 inflammatory granulation tissues. And there is no correlation between the presence of Hewlett globules and the acquired immune deficiency syndrome. So those Hewlett globules are mainly located in the cytoplasm, but they can also be found extracellular. The Hewlett globules, they do stain positive for periodic acid trypsin. They are negative for alpha-1 antitrypsin, alpha-1 anti-chymotrypsin, and lysozyme and factor VIII. There are quite a number of histopathological differential diagnoses in relation to Kaposi's sarcoma. It's very important probably to categorize them in according to the developmental stages of the Kaposi's sarcoma. At the early stage of Kaposi's sarcoma, one of the most important differential diagnoses is the inflammatory dermatosis, because the proliferation of the widely dilated vascular structures are not prominent at this stage, and the inflammatory cell infiltrates around the blood vessels may mimic many of the inflammatory dermatosis. Other differential diagnosis at this early stage of Kaposi's sarcoma is the interstitial form of granuloma annulare, where you have proliferation of lymphocytes and histiocytes between bundles of collagen in association with a mucin deposition in the reticular dermis. Another important histopathological differential diagnosis to the patch stage of Kaposi's sarcoma is a microvenular hemangioma in its early stage. For plaque stage of Kaposi's sarcoma, the so-called pseudo-Kaposi's sarcoma or the acroangiodermatitis is an important differential diagnosis, and the targetoid hemosideretic or the hobnail hemangioma, as well as the tufted angioma, are important differential diagnoses. For the nodular Kaposi's sarcoma, you have quite a number of differential diagnoses. The first one being the angiomatoid fibrous histiocytoma. The second one, the bacillary angiomatosis, which is also commonly found in immunosuppressed individuals in association with AIDS. The third one is dermatofibroma. The fourth one is lobular capillary hemangioma. The fifth one is spindle cell amelanotic melanoma. The sixth one is spindle cell sarcoma, like that of the dermatofibrosarcoma protuberans or the leiomyosarcoma. And quite a number of vascular tumors that are composed of spindle cells, like that of angiosarcoma, spindle cell hemangioma, and the Kaposiform hemangioendothelioma. I would like to point out the audience to refer the publication by Wadi and Grayson titled "The Cutaneous Kaposi's Sarcoma and Its Mimics." They have outlined in a very nice way the histologic variation of Kaposi's sarcoma and their differential diagnosis and the morphological characteristics. I think it's very important to mention the role of the immunohistochemistry in diagnostic capability of the histopathology of Kaposi's sarcoma. The CD31 and the D240 photoplanin are the new markers for lymphatic endothelium, and they are positive in nearly every case of Kaposi's sarcoma. The CD34 and the factor VIII related antigens were observed in some of the studies, but the antibody against the human herpes virus 8, the LNA1, is positive in majority of cases. And this immunostaining is confined to the spindle cells in the nodular stage, but they are also found in the endothelial cells in the early stage of Kaposi sarcoma and the patch stage. This slide is showing the human herpes virus 8, the LANA nuclear staining in many of the dermal spindle cells. This slide also shows the human herpes virus 8, the nuclear staining in a granular reactivity. So in summary, Kaposi sarcoma is a multifocal vasoformative tumor of endothelial cell origin. The condition occurs in 4 clinical variants, namely in its classic form, in the African endemic form, the immunosuppressive associated form following the therapy with immunosuppressive drug, and the S-associated form. The Kaposi sarcoma develops invariably. The development of Kaposi sarcoma is linked with human herpes virus 8 infection, and most importantly, it has a stage-dependent histopathologic characteristic, what we have described earlier. So a careful clinical history, physical examination, histopathological and immunostudies are critical, and the clinical pathology correlation is required for final diagnosis. So these are my references, and thank you for listening, and I will be available for questions and comments from the audience.
Thank you, Fuad, for this very complete lecture about Kaposi sarcoma. We will see if questions are coming from the audience. I'm introducing now the next speaker is Luli Kini. She's working since several years in Moshi, Tanzania, and she will present some cases, interesting cases with dermatopathological interest. Thank you, Luli.
Greetings, everyone. My name is Dr. Lulirita Kini. I'm a dermatologist working at Regional Dermatology Training Center, Moshi, Tanzania. We are going to have a brief discussion on a few cases that of persons living with albinism who present with conditions other than basal cell carcinoma and squamous cell carcinoma. Albinism is a genodermatosis that comes as a group. There are two forms, ocular albinism and oculocutaneous albinism. And both conditions affect production of melanin on eyes and skin and their appendages. In Africa, especially East Africa, albinism is of importance because of development of squamous cell carcinoma and basal cell carcinoma due to severe sun damage that affects these individuals. There are four forms of oculocutaneous albinism, but we are going to focus on oculocutaneous albinism type 2, which affects persons with albinism that live in East Africa. In Tanzania, the records show that 1 to 2,500 persons are affected with albinism. High concentration of the population are seen around the Lake Victoria zone, and this is due to the intermarriage in the villages. Now, in 1992, 30 years ago, the Regional Dermatology Training Center established outreach program to cater for persons living with albinism. As we see on the photo, the population of Tanzanians are small-scale farmers, hence they are exposed to the sun for most of the day. Now, for persons with albinism, they succumb to malignancies early. Unfortunately, they used to come to the hospital with quite advanced conditions, and this is why they started the program. Now, besides that, the other aims of the program was to provide education, health education to persons living with albinism, particularly on sun protection. The education also to the caretakers and teachers, especially for the young children living with albinism. Treatment of early malignance, early precancerous lesions with cryotherapy and possible referral for the ones that have been detected with advanced condition in the outreach. The commonest tumors that are observed are squamous cell carcinoma and basal cell carcinoma, as well as actinic cheilitis that are treated in the referral hospitals in various stages, and for the advanced malignancies are referred to the oncology centers. Coming to the cases that we have seen, the first case is a 15-year-old female living with albinism who presented with history of developing papules, which were erythematous. They started on the scalp around the ears, and then later on distributed to the upper trunk and then to the lower trunk. She had foul smelling, cast and discharge on arrival, and also clinically she had pitted lesions on the actual skin. Preliminary diagnosis was probably pemphigus foliaceus or extensive Bowen's disease and Darius disease. Punch biopsies were taken and showed these keratotic lesions as well as acantholysis with parakeratosis as well as numerous bacterial colonies on the stratum corneum. So the diagnosis of Darius disease was made And this is an autosomal dominant condition with problem in calcium concentration on adhesion molecules that leads to disruption of connection between the keratinocytes, leading to the acantholytic mechanism that we observe on the biopsy. Characteristically, clinically, usually the various disease present in puberty with greasy hyperkeratotic papules that become crusty quickly, and usually they develop also papules on the hands, also on the mucosal membrane, and the pitted lesions that are observed on the acral skin. Management of various diseases usually with isotretinoin. Now, coming to case number 2 is of a 30-year-old male who was seen also with a erythematous lesion on the cheek, which was pre-diagnosed as Bowen's disease or chronic actinic keratosis. He had multiple sessions of cryotherapy without improvement. So the doctors did a punch biopsy, which showed interface dermatitis with follicular plugging, as well as a little bit of pigment incontinence, but it is not as much pigment incontinence as observed on the black skin. So he was diagnosed to have discoid lupus erythematosus. The condition that usually affects females more, usually present with erythematous patches and flakes. Sometimes they have atrophy or hypertrophy at the center. Usually they affect the sun-exposed areas, hence the confusion with Bowen's disease or chronic actinic keratosis. He was managed with clobetasol, propionic, a program steroid with hydroxychloroquine. He's doing well. Now, the third case is of a 65-year-old female living with albinism who had an unknown history, unknown years of lesion on the acral site. She had come to the clinic because the lesion had become ulcerated, and a biopsy was taken which showed the acral lentiginous melanoma. Unfortunately, with the abdominal CT scan showed she had lymph node metastasis. The inguinal and the mesenteric lymph nodes were affected. However, the chest X-ray was clear. The patient was referred to the oncology center for further management. Malignant melanoma is not commonly observed in the persons with albinism community. Only 16 cases have been reported worldwide, and some are speculating it's because of maybe under-recording, because maybe we are missing the cases because most of them are melanotic. And the Polycode one, they did a follow-up of 350 Tanzanians living with albinism for 2 years, and they found only one patient developed malignant melanoma. The fourth case is of a 26-year-old male with albinism who came for routine checkup at the clinic. He had multiple excisions done for different tumors, but he had one nodule on the leg that was clinically diagnosed as basal cell carcinoma, which was ulcerated. And this biopsy showed a flea on the stomach, a flea on the skin, and that was diagnosed as candidiasis, which is also a common condition in the village communities because they do not wear shoes when they go to the farm. But what was peculiar with this case is because the lesion was actually on the mid leg, and Tunga penetrant fluid do not jump that high. So it was quite an interesting case to check. But coming to the clinical inspection, he had other nodules which were suspicious for triglycerides on the toes, and he was treated accordingly. So that's it with the cases. Thank you. And I'd like to welcome any comments and questions from the audience.
Dear Luli, thank you very much for your presentation. I think it is very, very important to show the relevance of the work of the Regional Dermatology Training Center for the people with albinism since almost 30 years. Thank you for showing us all this problem for these very, very ill patients. Maybe during the discussion you can say 2 words about the upcoming CME conference that is coming in January next year. I will text you. Now the next presentation is Marcus Starink. He is from Netherlands. He is a dermatologist with interest in dermatopathology. Marcus belongs also to the leaders of the European Academy of Dermatology and Venerology, and I'm very, very happy that Marcus is part of the leaders of this conference since the very beginning. 2015, we were in Moshi every year in January doing this conference. We were also together in Rwanda when we went in 2019. Now we are here online. Thank you very much, Marcus, for your lectures about granulomatous dermatitis.
Good afternoon, everybody. First of all, I would like to thank Helmut for the kind invitation. I'm very honored and very proud to be part of this 7th ADPC conference. This time I will give a presentation about the histopathology of granulomatous skin diseases. This is the layout of my presentation. I will start with a short introduction. Then I will go to the non-infectious granulomatous dermatosis. I will skip an important and big part of the granulomatous diseases, as Wayne Grayson already talked about the infectious granulomatous dermatosis. And I will finish with the granulomas in systemic diseases and syndromes. First of all, the cell where it's all about, the histiocyte. The histiocyte is a monocyte and it's also called a tissue macrophage. And examples in the skin are, for example, the melanophage and the siderophage. The function of the histiocyte is a kind of omnivore. It eats or encloses remains of dead or damaged tissue cells or foreign elements like microorganisms and foreign body material. This is the cell where it's all about, the histiocyte. Every time that I see a histiocyte, they always remind me of potatoes, as they kind of have the same shape and the same kind of structure. One of the features of histiocyte is that they can kind of cluster together and make giant cells, like you see here nicely and here also nicely. Another feature is they can kind of come together and make granulomas, which you can see as a kind of light purple areas in your skin biopsy. The definition of a granulomatous reaction pattern as defined by Whedon is an inflammatory reaction characterized by the presence of granulomas. And granulomas, as you can see, are relatively discrete collections of histiocytes and epithelioid histiocytes with a variable presence of multinucleated giant cells and other inflammatory cells. Granulomas can be classified based on histopathological subtypes. For example, you can have the sarcoid granulomas, which you can see here. You can have the tuberculoid granulomas, which you can also see later in the presentation, where you have central causation. You can have the necrobiotic granulomas, like in granuloma annulare. You can have the suppurative granulomas, which we will not discuss in this presentation because they are mainly seen in infectious diseases. And also an important one, the foreign body granuloma, which can be on exogenetic material but also on endogenic material. Based on where you are in the world, the infectious granulomas can be a substantial part of these granulomatous diseases. Up to 60% of the granulomas can be due to infections. When you see a granulomatous reaction pattern under your microscope, this is the histological approach. First, you have to characterize the granuloma. For example, if they are naked, which means that there are no other infiltrates within the granuloma or around it, if there is necrosis centrally, if there is abscess formation, if the granulomas are thin or translucent or not, then you have to see if there is association with other tissue structures like hair follicles, nerves, for example in leprosy, or in vessels. Then you have to check if there is association with altered tissue or material, for example necrobiosis or depositions. Always pay attention to excluding an infection, and when you suspect an infection based on the histology or based on the clinic, for example if you are in a tropical country, you can do stains, you can do PCR, and you can do culture. Always pay attention to foreign body material, and then you can use your polarized light and do depositions of endogenic material like keratin and crystals. This is the differential diagnosis of granulomatous diseases. The infections ones, as mentioned, I will not discuss, so we will limit this presentation to the non-infectious granulomatous diseases. We start with sarcoidosis. This can be a very easy diagnosis, both clinically as histologically, but also a very difficult diagnosis. And one of the reasons is that it can have multiple variations. This is one of the examples of the clinical spectrum. You can have micronodular or macronodular sarcoidosis, which you can see here. For example, also when you see the nodules on the nose, like in lupus pernio, you have to think about it. Also, you can have this plaque-type sarcoidosis, which is a more difficult diagnosis to make sometimes. Usually people do not really recognize it clinically, and then under the microscope you can make the decision. You can have the circinate or annular type, which is often confused with granuloma annulare, but can also be confused both clinically as histologically with leprosy. The macular type, which is sometimes a really difficult diagnosis, and then you can only see hyperpigmented or depigmented or hypopigmented macules. And you can also have different symptoms like the Kuppner phenomenon in scars or in tattoos, and erythema nodosum, like you can see here. This is the histology of sarcoidosis. On microscopy you see dermal aggregates of epithelioid cells, which you can also call epithelioid cell granuloma, and always compare it to basket with fat cakes, like you can see here. Also in histology you can see these fat cakes. And one of the features is that there is no or only a sparse mantle of lymphocytes, and that's why we can also call them naked granulomas, because they are not covered by lymphocytes or other inflammatory cells. In sarcoidosis you usually do not see central cassation or necrosis, which we'll come back to that later, and usually no foreign body material. There is, however, an exception. If you have, for example, the Kuppner phenomenon, you can see foreign material in your slides. When we zoom in, you can see these granulomas or these fat cakes better. And if you zoom in even further, you can here see nicely the giant cells. And again, here you do see lymphocytes, but they are very, very sparse. Another granulomatous disease is foreign body granuloma. And these foreign body granulomas, they can be caused by endogenous material like hair or keratin, for example, in ruptured folliculitis. You can also see it in calcinosis or in gout, where you see a reaction on the urate crystals, like you can see here. And it can also be based on exogenous causes like suture material, something that you can often see in re-excisions of melanoma, for example. You can see it based on rests of insects, like in scabies. You can see it in splinters, thorns, glass, sand, all kind of different materials. Here's an example of a foreign body granuloma with here fibrosis, and here you can see the granuloma. If you zoom into the granuloma, you can zoom in even further, you see here the foreign material, and well, this is quite classic of suture material. If you do have doubts, you can use your polarization on your microscope, and then you can see these suture material quite nicely. Dermal fillers can also cause granulomatous foreign body reaction. Here you can see them clinically. These are red nodules in the areas where the fillers were injected. And here you can see it histologically. Here you can see the filler material, and this can have different compositions. And here you can see the granulomatous reaction around it, the histiocytes, also the giant cells enclosing the foreign body material. Another granulomatous reaction is granulomatous rosacea. In granulomatous rosacea, you see red to yellow-brown papules and nodules of a size of 2 to 5 millimeters. They can be located in the face, sometimes periorbital or perioral, usually also on the cheeks. And it is quite a difficult diagnosis to make sometimes, because it's not very easy to distinguish it from acne acuminata or lupus miliaris. Some people think that it is a spectrum disease with granulomatous rosacea on one hand and lupus miliaris and acne acuminata on the other hand. Granulomatous rosacea tends to have a chronic course, and often it heals with scarring. On histology, you see well-circumscribed granulomas superficially and mid-dermal, and usually you can see them between the follicles. Sometimes there is central necrosis, and usually the granulomas are surrounded by neutrophils, lymphocytes, and also plasma cells. And classically, like in rosacea, Demodex is present if you look carefully. Sometimes a biopsy is taken of a red nodule in the face with the differential diagnosis sarcoidosis and rosacea. Then you would expect a pathologist to give you the answer, but this is sometimes very difficult, as both granulomatous rosacea and sarcoidosis can look similar under the microscope, and then you really need your clinical pathological correlation and sometimes multiple biopsies and also the time to see how it's developing. In the spectrum of granulomatous rosacea, there's also acne acuminata and lupus miliaris disseminata facei. Some people think that these are variants of granulomatous rosacea, and other people think that these are different entities. Usually, acne acuminata and lupus miliaris are more periorbital and periorally located, and usually it affects younger people. It usually starts suddenly and is self-limiting within 1 or 2 years, in contrast to granulomatous rosacea, which is usually a chronic disease. As in granulomatous rosacea, there is absolutely scarring, so this is not a feature that you can really count on to make the diagnosis. And usually there's no abundant Demodex, but it's certainly not excluded. Acne acuminata and lupus miliaris under microscope can be different from granulomatous rosacea. As in lupus miliaris and acne acuminata, you can see granuloma with central cassation. We will come back to that in the next slide. This cassation is surrounded by epithelioid histiocytes, giant cells, and also mixed infiltrate. So what is cassation? Cassation is apoptosis and necrosis of foamy macrophages. And if you compare the histiocytes, the macrophages, to potatoes, what I always think of the cassation is that these are actually mashed potatoes. Granuloma annulare is another very common granulomatous disease. It can have different subtypes, and one of the most well-known subtypes is the archiform or annular plaques of the hands, the fingers, the elbows, the knees, the ankle, the feet, and the toe. Granuloma annulare is in 85% of the cases localized, and 15% can be disseminated, and then it's sometimes more difficult to recognize. Granuloma annulare affects mainly female, but also male can be affected, usually younger people, but also older people can be affected, and classically you can see it in children. In the past, there was a strong suspicion that it was associated to diabetes, and people with granuloma annulare had to be tested for diabetes, but nowadays we think that it's not very common to be associated with diabetes. This is disseminated granuloma annulare of the annular type, and this is disseminated granuloma annulare of the papular type. And in histology, you can see in the dermis areas with a kind of light blue discoloration. It's called necrobiosis. And these areas, you can see them here centrally, are surrounded by histiocytes, which are arranged in a palisaded way. We will come back to that in the next slide. There is a slight perivascular lymphohistiocytic infiltrate, sometimes with some eosinophils. This is what I mean with palisading. These are palisades which you can have in your garden. Here is the area of the necrobiosis. It's grayish or light purplish. And then around this, there is this palisades of histiocytes, making this granuloma with this central necrobiosis, which is classic of granuloma annulare. Here again you can see this light purple or grayish discoloration with the palisades of histiocytes around it. Here you can see the patch type, the disseminated granuloma annulare, and this has a different histology. It's also called incomplete or interstitial granuloma annulare, and this is also where you have to look for a diagnosis, that is in the interstitium. In this you can see dermal areas with diffuse histiocytes. It's also called busy dermis with sporadic giant cells, and no or sparse degeneration of collagen. Actually, on this magnification you can really not make the diagnosis. When you zoom in, you don't really see it. Here you can see a perivascular infiltrate, but not much more. But if you then zoom in further, you can see here in the interstitium the histiocytes, sometimes some necrobiosis, but it's not as in the classical granuloma annulare which we saw in the previous slides. So sometimes a difficult diagnosis to make, especially when the clinician does not mention it in the differential diagnosis. And here you really have to zoom in to make the diagnosis. There is a variant of granuloma annulare, which is called granuloma multiforme. It is sometimes that I have never seen in the Netherlands, or actually never seen it in my life. But it's reported in Africa and India, and probably it's not really a separate entity, but just one of the variants of granuloma annulare. If you see this clinic, you of course have to be aware that it can also be tuberculoid leprosy. So really watch out before you make this diagnosis of granuloma annulare when you see this clinic. Another granulomatous disease is necrobiosis lipoidica. In necrobiosis lipoidica you can see yellow-brownish atrophic plaques with telangiectasias and red raised borders. In a small part, 35% of the people, you can also see central ulceration, and it can be very severe in severe cases. You can always, mainly see it in 85% on the shins or pretibial, and then it usually affects both legs, and sometimes in 15% of the cases you can see it elsewhere, and it can also be disseminated. In contrast to granuloma annulare, in necrobiosis lipoidica you really have to test for diabetes, because in 20 to 60% of the cases it is associated with diabetes. Here again we see food. This time it's not potato but lasagna, and the histology of necrobiosis lipoidica looks a bit like lasagna, because you see layers of necrobiosis alternated with fibrosis and an infiltrate of histiocytes, giant cells and lymphocytes. So if you see this kind of layered composition of histiocytes and necrobiosis and fibrosis, think about necrobiosis lipoidica. Usually it affects especially the lower dermis and sometimes even the subcutis and sometimes the upper dermis. There are also other systemic diseases and syndromes associated with granulomas in the skin. And one of the most important ones is rheumatoid nodule. We will come back to that later. Another famous one is Cheilitis granulomatosa, and cutaneous morbus Crohn is also a very well-known one. Rheumatoid nodules are the most frequent skin manifestation of rheumatoid arthritis, and it can be seen in 20 to 30% of the people with rheumatoid arthritis. Usually you can recognize them clinically as skin-colored or red, deep solid nodules, and classically they are not very tender. You can find them near joints, and sometimes they are very difficult to distinguish from deep granuloma annulare. Sometimes they can be solitary, and sometimes they can be multiple. One of the things where you have to look at to make the distinction with granuloma annulare is to see how deep the abnormalities are in the biopsy. In granuloma annulare you can usually see the abnormalities higher in the dermis, and in rheumatoid nodules they are usually located deeper and sometimes even in the subcutis. The abnormalities consist of multinodular extensive fibrin depositions and necrobiosis in the center, and they are surrounded by a well-developed palisade of histiocytes and giant cells, and around that a mixed infiltrate. So we will come to the end of the presentation with one very important take-home message. When you see a granulomatous infiltrate in a tropical country, always first exclude an infection. For example, use stains, culture and PCR if necessary, and also look at the clinic. So again, the histopathological or the clinical pathological correlation is essential. When you suspect a granulomatous reaction pattern, you have to characterize the granuloma. see the nature, for example, if it's naked, like in sarcoidosis. Is there necrosis or abscess formation, like you can see, for example, in infections? Or if it's thin and translucent, then you have to check if there is association with tissue structures, like hair follicles, like in rosacea, or in ruptured folliculitis. Is there association with nerves, for example, in leprosy, or association with vessels, like in granulomatous vasculitis? And then you have to check if there's association with altered tissue or altered material, necrobiosis, for example, in granuloma annulare, or depositions. Always pay attention to foreign body material, and if you doubt, use the polarized light of your microscope, and to deposition of endogenic material like keratin or crystals. And again, when you do have doubts clinically or histologically, it's very important to exclude infection with PCR culture or stains. That brings me to the end of my presentations, and if you do have questions, I'm open to questions right now. Thank you.
Hello again. Thank you, Marcos, for this complete, nice presentation about granulomas. The next speaker is Jason Sluzevich. He's from the United States of America. He's a dermatologist and dermatopathologist. He is also part of the team of this African Dermatopathology Conference since a couple of years. Thank you very much, Jason, that you're speaking here, and you are updating us about immunobullous disorder without direct immunofluorescence. Thank you for your talk.
My name is Dr. Jason Sluzevich, and I'm one of the staff dermatologists at the Mayo Clinic in Florida. And today I'm going to talk about blistering disorders and using a clinical pathologic approach to diagnosis. So generally, when we think about blistering disorders, we emphasize the role of immunofluorescence in diagnosis. But generally, however, if we use routine histopathology and we combine that with the clinical features that define these blistering conditions, we generally can come up with very accurate diagnoses even in the absence of immunofluorescence studies. So the baseline clinical care scenario that we're going to be looking at today is a patient with chronic blisters or erosions, and that may or may not be associated with mucositis. And fundamentally, what we need to do to help these patients is we definitely need a biopsy, and we need to preferably have a biopsy of an intact blister. We'll usually do this with a shave technique, and it's important to include uninvolved skin perilesional to the blister, because this can contain very important information histopathologically. In some cases, depending on the blistering disorder we're dealing with, we may only have an erosion to biopsy, and that's often common in the workup of mucositis as well. But as long as we again have some adjacent normal appearing skin, generally we can improve our diagnostic yield greatly. So we're going to begin with the pemphigus group, and that's because most of the disorders that are associated with pemphigus can be diagnosed with histopathology alone. So pemphigus vulgaris is characterized by suprabasilar acantholysis, but sometimes it's confused with Hailey-Hailey disease, and pemphigus foliaceus, the findings are a bit more subtle, but it's characterized by superficial acantholysis with hypergranulosis and loss of the stratum corneum, and sometimes these changes can be confused with Darier's disease. One of the important things in this is just to recognize, even though these conditions may have some degree of histopathologic overlap, clinically they're somewhat distinctive, and it reinforces that histopathology is always more powerful when it's correlated with clinical findings. So this is a patient I've recently started taking care of. He presented with several-month history of erosive change involving the torso and the face, and his eye, actually the external eyelid, was prominently involved. But what's notable here is that there is no symblepharon or other forms of conjunctivitis. This was associated with stomatitis involving the oral cavity. And in fact, this is how the condition first developed. And you can see there's significant involvement of the buccal mucosa, and there's more superficial involvement of the soft and hard palate. So let's take a look at his biopsy. So we followed our rule and did a very nice shave biopsy so we can see the intact blister cavity, and then we have an adjacent area of normal clinically uninvolved skin. Now when we look at the center of the blister cavity, it's quite busy. We can confirm that we're dealing with an acantholytic process because the cells are separating from each other and becoming rounded, but in some areas there's broad areas of necrosis, and anytime we're trying to define a blistering disorder, we're really trying to figure out where the cleavage plane is. If you start focusing on these areas, you could even consider the possibility that there's some viral cytopathic effect, and that this is perhaps a herpetic type process on histopathologic grounds alone. If we look at the edge of the blister, though, we can see the characteristic change, which is suprabasilar acantholysis. So basically, everything above this above the suprabasilar keratinocytes detaches, and that defines the cleavage plane that is seen with pemphigus vulgaris. What's important to note here is that we don't see a lot of dyskeratosis in the area where the blister first develops. Now, many immunobullous diseases, and pemphigus vulgaris is no exception, can be associated with eosinophilic spongiosis. So typically there's a dermal eosinophilic infiltrate, and then a portion of those eosinophils exocytose into the epidermis and cause spongiosis. And then in those areas, oftentimes the acantholysis will develop. Pemphigus vulgaris is often associated with what we call the tombstone sign histopathologically because of the clear suprabasilar acantholysis. The basilar keratinocytes remain attached to the dermis, and this is supposed to be reminiscent of a row of tombstones. Follicular involvement often occurs early in pemphigus, and it can be a very helpful clue in the diagnosis. And this is a scalp biopsy of a different patient, and you can see the significant follicular acantholysis that was associated with this biopsy. Now, a common confusion is Hailey-Hailey disease, and part of the confusion involves that in certain areas you may have a similar suprabasilar pattern, but it's important to note that in Hailey-Hailey disease, the entire epidermis shows acantholysis, and it's not just limited to the suprabasilar component. And if we look at the hair follicle, we'll see that it is not involved. The term dilapidated brick wall is used to refer to this full thickness acantholysis that characterizes Hailey-Hailey disease. So how does Hailey-Hailey disease present? Well, it's going to be different than pemphigus in many cases, so certainly different than pemphigus vulgaris because pemphigus vulgaris will be associated with stomatitis. And in Hailey-Hailey disease, the vesicles and erosions predominate in a flexural distribution, where in pemphigus we're generally going to see a seborrheic distribution that is often more photo-distributed. Another characteristic clue clinically with Hailey-Hailey disease is in the areas of the erosive change, there are these fissures or linear erosions, and this can be a helpful clue. Also, the history of when Hailey-Hailey flares and when it onsets will be very different than most cases of pemphigus. So Hailey-Hailey will have an earlier onset and will have a relapsing course that's associated typically with irritant factors, sweat and heat, that then can be complicated by superinfection. And this early onset is due to this being a genetic condition, an autosomal dominant condition. So there's a defective calcium channel pump. And as we know, calcium homeostasis is very important for epidermal differentiation. In this example, we're seeing a vegetative plaque in the axillary vault. So morphologically, this certainly could be consistent with Hailey-Hailey disease. What you'll note here, though, is that there's a little bit more acanthosis to the lesion, and we can tell this by this accentuated skin lines. And in the areas where we have the erosion, it's more geographic, and there's a lot of prominent serous and hemorrhagic crust. So if we take a sample of this, we see something that clearly isn't Haley-Haley disease. We see florid eosinophilic spongiosis, variable degrees of prominent epidermal acanthosis, focal suprabasilar clefting, and then extensive dermal eosinophilic inflammation. And this combination of pattern in terms of histopathology defines pemphigus vegetans. So this is a rare form of pemphigus. It will present mainly with vegetative plaques rather than superficial erosions in intertriginous and flexural areas. Stomatitis is common, and although there is a clinical overlap perhaps with some forms of Haley-Haley disease, the histopathology is very characteristic. So this is another patient that I've been following for some time, and what was interesting is he presented to me with complaints of dyspigmentation on his face. So he said his face was burning and turning brown. But then when you examine him fully, he actually did have these focal areas of erosion. And if you look very carefully, there was actually a small intact vesicle. But that really wasn't the thing that bothered him. It was really this photosensitivity. And in an up-close view, we can see that these clearly are erosions, with here a small vesicular lesion. So this is his biopsy, and there's a couple important points to this biopsy. So the first thing you'll see is at the edge we have an intact stratum corneum, but as we move to the center of the lesion where there appears to be more inflammation, we see progressive parakeratosis, and a well-defined stratum corneum essentially disappears. If we go higher, we see focal eosinophilic spongiosis, which is characteristic of the pemphigus group and immunobolus disorders in general. And then a higher power view of that area that looked more inflamed, we see two important changes. We see acantholysis in this upper granular layer. You can see the cells are pink and kind of elongated. And then the granular layer becomes a bit more prominent and hyperchromatic. And so this increased prominence granular layer with superficial acantholysis and loss of the stratum corneum is very characteristic of pemphigus foliaceus. Now, sometimes those changes can be confused with what we see in Darier's. So Darier's is also a form of acantholysis, but with Darier's, there's prominent dyskeratosis. So we have these rounded cells that are red and become rounded. And then there are two things, the chorons, which are these basophilic type cells that have a clear halo, and then these core grains, which I like to call them plump parakeratotic cells. And it's these three things together that define Darier's disease. And the key feature which separates it from pemphigus is the presence of the dyskeratosis. So this is a case of Darier's, and so it would present, of course, clinically quite different than pemphigus. Rather than getting erosive lesions, we have these warty keratotic type papules. Patients with Darier's disease have characteristic nail findings, this red-white striping of the nail, and often these palmar pits. So there's clinical features which allow easy separation from most forms of pemphigus. Here's another patient that presented with these crusted vegetative lesions on the torso. Certainly in isolation, this could be a case of Darier's. And up close, you can see the lesions are quite vegetative and inflamed. But when we look histopathologically, we have kind of a mixed picture. We have on one edge supravasilar acantholysis, so something that we would potentially see with pemphigus vulgaris, but then in other areas, more classic findings of focal acantholytic dyskeratosis. So again, the acantholytic dyskeratotic cells with the plump looking parakeratotic light cells, which are the core grains, and then our cororons here with the halos. So this biphasic pattern would favor Darier's, and that of course fits best clinically. This patient presented with these grouped erosive lesions on the torso. They were moderately itchy, and you can see they have this grouped almost herpetiform type pattern. And if we look up close, we can see that morphologically there are these superficial vesicles that very quickly form hemorrhagically and seriously crusted erosions. And so if we take a sample of this, we see three major things. We see an interepidermal vesicle with eosinophils. There's some features of eosinophilic spongiosis, but what's different than some of the things that we've looked at before is we're not seeing a lot of acantholysis and a lot of dyskeratosis. And so this is just to give you a broad overview of the lesion. When you look at this, your first thing may be, is this eczematous? I have this really large interepidermal vesicle, but let's look at this up close. So we can see at the edge there's clear evidence of eosinophilic spongiosis and an associated dermal eosinophilic infiltrate. And then if we look at the blister cavity, we can see that it's filled with eosinophils. There's surrounding eosinophilic spongiosis, but there are not well-developed numbers of acantholytic cells either in the blister creating the blister cavity. So it's really more a consequence of the progressive eosinophilic spongiosis forming an interepidermal vesicle. And we can see kind of the EO both in an area that is precursor vesiculated and then floating in the cavity itself. And so this is actually a rare form of pemphigus. It's pemphigus herpetiformis. It is characterized by what we described eosinophilic spongiosis, mainly with variable degrees of interepidermal vesicles. They are usually eosinophils, but sometimes they can be neutrophils, and it's associated with minimal acantholysis. So these patients tend to be paritic, and they tend to have lesions on the trunk and proximal extremities. They can adopt a grouped or herpetiform configuration, and oftentimes this is very indolent, but some cases can evolve into either pemphigus foliaceus or pemphigus vulgaris, both clinically and histopathologically. And this is probably the one subtype where the DIF is probably the most important, because this certainly could be confused in some situations with bullous pemphigoid, but we know fundamentally this is related to the pemphigus group, because when we do direct immunofluorescence, we'll see a pattern that is characteristic of either PV or PF. So this eosinophilic infiltrate is a nice segue to other eosinophilic infiltrates that can define blistering disorders. And so here we have this elderly gentleman with numerous urticarial type plaques, and these have variable degrees of vesicular and erosive change. In some areas, the blisters are very, very tense, which is a feature that we commonly see with any subepidermal blistering process. If we take a look at the biopsy, we can see indeed there is a subepidermal blister, and this is really loaded with eosinophils, large numbers of eosinophils within the blister cavity. And we can see the roof of the blister is here. There are really no cells aligning the base, in contradistinction to some of the patterns we saw in the pemphigus group. And this biopsy, there's fluorodermal eosinophilia, although the degree of this will vary between specimens. This is an additional up-close view of the blister cavity, and you can see that essentially 90% of these cells are in fact eosinophils. As the blister becomes turbid, the neutrophilic infiltrate will increase, and that sometimes can prevent some diagnostic problems. But generally, bullous pemphigoid is uncommon prior to the age of 40. It's usually elderly people. These patients are generally very, very itchy. It does have a flexural predominance with numerous intact bulla, and sometimes there can be localized variants, so it can localize pretibitally or it can localize on the breast. There are drug-induced variants, but the take-home message is that a subepidermal blister with eosinophils is generally virtually diagnostic of BP, especially if it's combined with the clinical factors that we described, and also if it is very prednisone responsive. So bullous pemphigoid is a very prednisone responsive condition, and so if you have someone who you think is bullous pemphigoid and they're not responding to prednisone, it's a reason to perhaps reconsider the diagnosis. Now, some cases of bullous pemphigoid will present like this. So we don't really see a blister cavity. We just see lots of eosinophilic spongiosis and large numbers of eosinophils that align at the dermal-epidermal junction. Sometimes they'll form micro vesicles that are loaded with eosinophils, so extreme eosinophilic spongiosis, but this may not be perceived clinically as a vesicle. And this is the so-called urticarial pemphigoid. These patients will present with a similar level of generalized pruritus, and then have urticated lesions that are fixed, that again are typically flexural. In some cases, they'll adopt a more dermatitic appearance, and a biopsy with large numbers of eosinophils approaching the dermal-epidermal junction with variable degrees of eosinophilic spongiosis is certainly suggestive. What's important to note is that if you get deeper dermal inflammation, things like dermal hypersensitivity, Wells-like, eosinophilic rich urticaria, that's typically not associated with an immunobolus process. Most of these patients will declare themselves, so they'll ultimately blister, but there is a subset that remains stuck in this phase. A portion of patients, though, very interestingly, is very responsive to doxycycline. So if you give them doxycycline, usually 100 milligrams twice a day, and generally after 4 weeks, many of them will improve, and that can be another empiric way of testing about whether this is, in fact, the diagnosis. Here's another patient, and what I think you can see morphologically that is most striking is the annularity of these lesions. So we have these confluent lesions that have the striking annular or arciform configuration, and then at the edge of this there is erosion and crusting and vesiculation. And so if we do a biopsy, we also have a subepidermal blister. In this case, there's a lot of hemorrhage, so you can see these red blood cells, but if we go higher, we can see that the blister cavity is really loaded with neutrophils. So this is an overwhelmingly neutrophilic subepidermal blister. Anytime you have a lot of neutrophils, you may have 1 or 2 eosinophils come along for the ride, but in general, this is, as the histopathology shows, predominantly neutrophilic. And this is a case of linear IgA disease. This typically will present as a generalized eruption. More than half will have mucosal involvement. The amount of itching is very variable between patients, and annularity is common, but it doesn't always have to occur. So this actual patient also has linear IgA disease, and there are some lesions here that maybe are suggestive of an annular process, but really in some cases this almost looks eczematous in other areas, and superficially erosive, so even you could potentially consider even like a pemphigus foliaceus. When you're thinking about linear IgA disease as a diagnosis, you need a good drug history, because drugs are common in terms of an etiology, and the histopathology of this will overlap with dermatitis herpetiformis and bullous SLE, but clinically, morphologically, they're very, very different. So basically, polymorphous blistering eruption with a subepidermal blister with neutrophils strongly favors LABD as a diagnosis. So this is another biopsy that I recently encountered, and what we can see here, again, we do have a subepidermal blister, and there's a large numbers of neutrophils that are in the papillary dermis and within the blister cavity. We can even see that better here. And so my initial read on this was, oh, this is going to be a case of probable LABD. But this is actually how the patient presented. He presented with crusted vesicles in the buttock area in the setting of significant generalized pruritus. So again, it illustrates that there is this overlap with LABD. One clue that sometimes favors DH, it's a soft clue, is when you have this multifocal papillitis. So you can see that here there's focal areas of papillitis that are adjacent to those more broad areas where we saw the neutrophilic inflammation. But again, clinically, we're not going to confuse this with LABD. And then these patients are the ones that really have a dramatic response to dapsone. So if you give them dapsone, typically within 96 hours, their itching disappears and they rapidly improve. So there's, again, other clinical ways to separate this. Here's a more conventional, another conventional presentation. These are more end-stage lesions, so you can see that there's almost there's maybe a few crusted areas here that would be good to sample, but if you sample here, you're probably just going to get more of a healing skin response. And so oftentimes in DH, even when your clinical suspicion is high, you can get some non-diagnostic biopsies, things that just show dermal fibrosis or healing skin response. And if that's the case, but the distribution is otherwise characteristic of DH, then an empiric trial of dapsone would be warranted in terms of helping you to sort the diagnosis out. This is a more conventional biopsy for dermatitis hepatiformis, and what it's really emphasizing is the prominent neutrophilic papillitis, and at higher power you can see that, and then you get the focal blistering split that is characteristic of this subepidermal blistering condition. This is another patient that I do follow, and she's very interesting. So she presented with basically photodistributed milial type eruption in the setting of a tense extensor blister, and then a lot of acral blistering, again with numerous sort of milia. And the key clinical feature here on her biopsy is, again, we have a subepidermal blister with numerous neutrophils. And you can see this in the blister category, but this person actually has lupus. Okay, so this is a case of bullous SLE, so this always will be seen in the setting of lupus. Her ANA was very high, and she had some other ENAs which were also positive, but these don't need to be positive to make this diagnosis. Generally, this is going to be their only manifestation of cutaneous lupus, so they're not going to have discoid lupus. They're going to have a very clear history of SLE, so typically this isn't so much of a surprise. The milia, especially in these sort of photodistributed locations, can be characteristic. It can sometimes clinically overlap, especially when it predominates on the extensor and acral surfaces with EBA clinically. But again, the histopathology will be pretty, allow us to separate that. Also, the clinical situation is different with this setting occurring in lupus. And classically, the treatment is dapsone, although I would say in my hands it doesn't work nearly as well, but often rituximab, which in many blistering disorders is helpful, is the treatment of choice. So this is another one of my long-term patients, and he presented with the sort of cicatricial areas involving the torso. And you can see that when these resolve, they resolve almost with a scarring-like pattern. And then there's some tense vesicles here. A lot of involvement of the upper thigh, but really his hands were where he had probably the most chronic involvement. You can see there's a tense vesicle here, and then there's some milial type change here. So this is his biopsy. Again, we have a subepidermal blister, and in the blister cavity, it's mixed. So we see eosinophils and we see neutrophils. So this is one of the more histopathologically ambiguous patterns. This pattern could be seen with EBA or with BP, and so you can't, on histopathologic grounds, necessarily know what the patient has based on the histopathology alone. Now, this patient also had milia, and this milia was also associated with this dermal angiofibroplasia. So this sort of pattern of milia and scarring is not something that we generally see with most cases of pemphigoid, and so that could be helpful if you have milia and these changes, and trying in terms of establishing if you think this is EBA versus some form of BP. Now, you can actually use immunohistochemistry to help sort this out. Oftentimes, practically, it doesn't make a difference, but when we have EBA, we have a problem with collagen 7. So we have autoimmunity against collagen 7. So there's essentially autoantibodies against a domain of collagen 7. Okay, typically we establish this using indirect immunofluorescence with salt split skin. And so what that does is it causes an artifactual split through the lamina lucida. And then when you stain the immunoreaction, they are basically at the base of the blister because we're splitting here, and here's where the immunoreactions are co-segregating. So the top at the epidermis, there's nothing, but at the base we see the immunofluorescence. If you have an intact blister, what we can do is stain to type 4 collagen, and oftentimes immunohistochemistry is much less expensive than immunofluorescence. And this works because the lamina densa is actually got a lot of type 4 collagen. So if we're staining for type 4 collagen and then the blistering reaction is occurring here, what we would expect is the lamina densa is going to separate from the collagen fibrils, and then we'll in fact see it at the top of the blister cavity, and that's exactly what we see here. So here's the internal control. You can see we're staining for type 4 collagen. The vessels are lighting up. Here's our blister. We can see nothing at the base, but it does stain the top of the blister cavity. So immunomapping can be used in some cases if it's necessary to distinguish the two. So basically, in summary, the pemphigus group is histopathologically the most specific, and there are notable clinical differences between the different subtypes. So if we have a situation where there's suprabasilar acantholysis, oral mucositis, and cutaneous erosions, we can be relatively confident that that's PV. And similar with the other clinical and histopathologic features of foliaceous and vegetans, we can get to a very specific diagnosis. Subepidermal blistering disorders are classified by inflammatory cell type. If it's eosinophilic, it's likely to be bullous pemphigoid. If we have a mixed blister, it could be EBA, but there are other features like milia, acral accentuation, and generally more treatment resistance that can help to sort that out indirectly. In many cases, this distinction may not matter, because if you have a treatment-resistant case of BP and a treatment-resistant case of EBA, what you're really saying is that they're prednisone-resistant, and therefore they're going to need some sort of steroid-sparing agent. And so generally this would be Cellcept. And then the neutrophilic blistering disorders are the ones that they all really look very similar. There are subtle differences in terms of the distribution of the neutrophilic papillitis, and where the neutrophils line up on the dermal-epidermal junction, but really it's the clinical situation between each that makes them easily splittable. So once you know you have a neutrophilic-rich subepidermal blister, you simply correlate with the clinical and you can get the right diagnosis. So I appreciate everyone's attention. I'm going to kind of leave my email here. In the interest of time, I didn't talk about MMP and some of the other blistering disorders that present with mainly mucositis, but a similar schema can work, and hopefully at a later date I'll be able to share that with you and hopefully in person. Stay safe, everybody.
Thank you, Jason, for your contribution from Florida. I'm sure the African colleague appreciate a lot this lecture based on histological patterns for bullous diseases without immunofluorescence. I underline this because I was working in Africa, and I'm sure, unfortunately, several laboratories in this continent still don't have the possibility to make immunofluorescence. So you have to deal without this technique to make the diagnosis of bullous disease. Now we go to the next speaker. The next speaker is Marwa Mubarak from Egypt, and she is a dermatologist with interest in dermatopathology, and she will present some cases, some interesting cases. Please, Marwa.
Hello, everyone. I'm very happy to be with you today in the 7th African Dermatopathology Conference. My name is Marwa Zohdi Ali Mubarak. I am a lecturer of dermatology from Mansoura University, Egypt, and have done a DermPath training at Inselspital Bern, Switzerland. Today, I will discuss with you some clinical cases that from my daily practice. To start with my first case, a 58-year-old man presented with asymptomatic reddish dark generalized skin eruption of gradual onset, progressive course, and 1-year duration with no constitutional or other systemic symptoms. On examination, examination revealed multiple small to medium-sized telangiectatic macules and patches with hyperpigmented tinge, and both trunk distributed on both front and back of the trunk, and extremities with negative derriere sign. This is the distribution of the lesion on the front and back of the patient, on both forearms, on the front and back of the shoulders, and this is more close-up view of the telangiectatic macules with slightly hyperpigmented background. Were found also on the knees. Little lesions were found on the side with the slight pigmentation. More close-up view showing these telangiectatic macules on hyperpigmented background. So there was no history of bleeding tendency or medical condition, no history of drug intake or operation, no family history of similar condition. General examination revealed no mucous membrane involvement, no signs of liver cell failure. Our clinical differential diagnosis included spider angiomas, hereditary hemorrhagic telangiectasias and generalized essential telangiectasias, cutaneous collagenous vasculopathy, and telangiectasia macularis eruptiva persistens. Laboratory and radiological investigations done were all normal, including the complete blood picture, bleeding and clotting times, the liver and renal functions, X-rays and CT chest, and abdominal ultrasound. Spider angiomas here were excluded due to absent central arteriole in the clinical presentation, the distribution of the lesions below the level of superior vena cava, absence of symptoms and signs of liver cell failure. The other forms of telangiectasia, like hereditary hemorrhagic and generalized essential telangiectasias, were excluded due to the older presentation of the lesion, shorter duration, absence of bleeding from other mucous membranes or from the orifices, and negative family history. Dermoscopy of the lesions revealed linear and branching telangiectasias with a background of reticulate pigmentation. This is a more close-up view of the dermoscopic finding. We see the reticulated network of dilated capillaries, telangiectasias, and the background of reticulate pigmentation. Histopathology revealed increased pigmentation in the basal cell layer with small telangiectatic vessels in the derms, upper derms, and sparse perivascular mononuclear and spindle cell infiltrate. This is a more higher magnification with evident increased pigmentation in the basal cell layer, the presence of telangiectatic vessels, and the mononuclear infiltrate. We notice here some spindle-shaped cells. These cells were showed positive staining for Giemsa stain. We will see now a more higher magnification of these cells. These spindle cells shows positive staining with Giemsa stain. We see here also the dotted pigmented residues in the derms that represent or reflect as hyperpigmentation on clinical background. This histopathology excludes cutaneous collagenous vasculopathy and generalized essential telangiectasias because both show perivascular hyaline thickening, which is PAS positive. So in our case is PAS negative. So our final diagnosis according to this clinical pathological correlation is telangiectasia macularis eruptiva persistens, which is a disease was discovered by Barks-Weber in 1930, is a rare form of mastocytosis occurring in adult and rarely in children, characterized by extensive eruption of brownish red macules with fine telangiectasias, with little or no artication or diarrhea sign. Clinically, they are very persistent and resistant to therapy. Most cases are limited to the skin with no systemic involvement, mainly located on just the chest and extremities, while systemic involvement rarely may occur, involving the bone marrow, GIT, liver, spleen, and lymph nodes. Hematological abnormalities associated with multiple myeloma and polycythemia vera. Histopathology of classic telangiectasia macularis eruptiva perstans includes the typical infiltrate of mast cells around venules and dilated capillaries of the superficial venous plexus of the derms, together with positive staining, of course, to confirm, with Gims stain or Tolidin blue to highlight the mast cells due to the presence of metachromatic cytoplasmic granules. Dermoscopy of the lesion shows the characteristic vascular pattern and reticular hyperpigmented network. And this is helpful to differentiate it from other forms of mastocytosis and other skin lesions with vascular pattern. Treatment lines, there is no gold standard medications. However, it depends on the presence of systemic involvement of the clinical symptoms. So the usual lines of mastocytosis, together with the intensive pulsed dye laser because of the vascular component, and electron beam radiation. Other therapies include ketotifen, doxepin, chromomyelin, sodium, topical and systemic steroid, leukotriene antagonist, and alpha interferon. This is a case report published 2013, which revealed typical clinical and dermoscopic finding in a patient with no systemic symptom similar to our case. These are the clinical and the dermoscopic findings, and these were the pathological pictures of the patient. This is the hematoxylin, and this is the Gims-sustained spindle-shaped cells. We found another recent case report in 2020 in the Journal of American Academy Case Reports, of dermatology case reports, telangiectasia macularis eruptiva perstans, but in presence of liver cirrhosis. So this patient was hepatic. That's why here the more differential diagnosis was more towards spider angiomas. Though clinically it's very similar to our case, and also the pathology revealed the presence of perivascular spindle cell infiltrate with positive staining. However, here the case should be differentiated from spider angiomas, which show the characteristic feeding vessels, both on the clinical and the feeding central arteriole, both on clinical and histopathological background. And of course, there is no pigmentation. So please take this home message. Telangiectasia macularis eruptiva perstans is a rare form of cutaneous mastocytosis in which the dermoscopy is useful together side by side with the histopathology together with clinical pathological correlation. Our second case is a 60-year-old woman complaining of painful skin lesion on the vulva with gradual onset and progressive course 6 months duration. She had a history of radical cystectomy 2 years ago. On examination, there was a solitary, well-defined, raised eroded erythematous plaque on the left side of labia majora, and there was no lymph nodal involvement, negative colonoscopy, there's no masses or something, pelvic examination or anything, there was no abnormality. This is a more close-up view of the ulcer. We saw like eroded ulcer with granulation tissue present on both sides, but more extensive on the left side of labia majora. Our clinical differential diagnosis was cutaneous metastasis, extramammary Paget's disease, Pound's disease, and squamous cell carcinomas, pemphigus vegetans. Histopathology revealed the presence of Pagetoid cells infiltrating the epidermis with no invasion of the derms. There also was a band of lymphocytes at the dermo-epidermal junction. Here is a more higher magnification of the intraepithelial Paget cells, which are neoplastic, large, round, atypical cells with pale cytoplasm and large nuclei with prominent nucleoli and distributed singly in a Pagetoid pattern in the epidermis. We here also notice mounds of parakeratosis. So here, the pathologic differential diagnosis, in case you see this pattern pathologically, you should think of extramammary Paget's, of course, but also you should exclude Pagettoid Bounce disease and Pagettoid melanomas. So we did an immunohistochemistry panel, and we did pan-cytokeratins to exclude squamous cell carcinomas, S100 to exclude melanomas, cytokeratin 7 for primary extramammary Paget's, and cytokeratin 20 for secondary extramammary Paget. Epithelial membrane antigen marker of adenocarcinoma, we did also it to exclude adenocarcinoma, and carcinoembryonic antigen, which is a marker of adenocarcinoma of goblet cells of the gastrointestinal tract. So this is necessary to exclude the important differential diagnosis we said, and to differentiate also between primary and secondary extramammary Paget's disease. So pan-cytokeratin was negative, excluding squamous cell carcinoma or Bounce disease. S100 also was negative, excluding melanoma. EMA was positive, confirming the extramammary Paget's, the ductal origin of the cells. And cytokeratin 7 was positive, confirming the primary origin of the cells, while cytokeratin 20 was negative, which favors the cutaneous origin and excluding the secondary extramammary Paget's due to visceral malignancy. CEA was negative, so it's not from a gastrointestinal origin. So to summarize, our case showed a Pagettoid pattern of cells in the epidermis that are CK7 positive, EMA positive, CK20 negative, CEA, pan-cytokeratin, and S100 negative. So according to this clinico-pathological immunohistochemical correlation, our final diagnosis is primary extramammary Paget's disease. So extramammary Paget's disease is a common intraepithelial adenocarcinoma that may be arising from two theories we have about the origin, maybe from the pluripotent stem cells within the epidermis or the intraepidermal apocrine cells present in the poral portion of an apocrine glands. The vulval form of extramammary Paget disease occurring in less than 2% of primary vulval neoplasms, few cases associated with cutaneous sweat gland tumors. Most of them are primary, and secondary cases may be associated with neoplasms arising in the bladder and urethra. And here you remember our patient had radical cystectomy 2 years ago. So vulval extramammary Paget clinically is non-specific, has non-specific features, just maybe a plaque or ulceration, but may be misdiagnosed for this case as lichen simplex chronicus, psoriasis, Bounce, moniliasis, pemphigus vegetans, whatever. Treatment lines include wide local excision, and this occurring with relatively high recurrence rate due to the multifocal nature of the disease, and that's why long-term follow-up is recommended. Others include most micrographic surgery in a specialized center, use of horizontal sections for frozen sections of entire periphery or to excise lesion, and this leads to complete surgical clearance. Non-surgical treatments is not suitable if it is invasive, including radiotherapy, topical chemotherapy with intralesional interferon alpha-2b, carbon dioxide laser, photodynamic, topical 5-fluorouracil, or imiquimod 5% cream. Several case reports and literature about the extramammary Paget's of the vulva. We will here discuss two of them, one in 2017, Indian Journal of Sexually Transmitted Diseases and AIDS. Here, the more fungating lesion with more extensive ulceration of the whole, taking the whole labia majora. And histopathologically, it's also revealing the Pagettoid spread towards the epidermis. Other one, recent one in 2021, report of two cases in Medicina journal. And here is more also fungating mass with no ulceration. See here, it's a vegetating lesion that needs wide local excision, and also revealed to be Pagettoid Paget cells in the epidermis, which were cytokeratin 7 positive and were HMB and S100 negative excluding vegetoid melanomas. So our message in this case that skin biopsy should be obtained from any persistent vulval or perianal eczematoid lesion that's unresponsive to traditional local therapy. And in the primary extramammary digit, you should do cytokeratin 7, which should be positive, while in secondary cases, cytokeratin 20 is usually positive. I'd like to thank you all very much for your attention.
Thank you, Marva, very much for the presentation of these two very interesting cases with clinical pathological correlation. Let's see if there are questions in the audience later. So the next speaker, we have a small change in the program. Yesterday, Alice Amani from Rwanda couldn't speak due to technical reasons. So we will listen to her lecture today. And Alice is building up a residency program in Rwanda. It's the first residency program for dermatology in her country. And my compliments, Alice, for this new big deal that you have. Now we will listen to your lecture about lichenoid dermatitis.
Dear Helmut, it seems that Alice, because we were a little bit fast with our schedule, so Alice is not here at the moment.
I can show you something. I can share a PowerPoint presentation that I wanted to show during the discussion, but I mean, I wanted to show the story of this conference in 2 minutes in a PowerPoint. I can show this. I share my screen.
That would be very nice, yeah.
And I have to take slides and then PowerPoint.
But now it looks good. Give me a second. She's here.
Okay, try to see. I continue to look my conference and then I just take 2 minutes if.
Exactly, yeah.
If you want, I'm ready. Or I do it later and Alice, should I go?
Yes.
Okay, we have a little delay with the next presentation. I take the occasion to show you a couple of slides about this conference. We are having now the 7th African Dermatopathology Conference. This is the first time that we are doing an online meeting. Last year, we couldn't do the meeting because of Corona pandemic. I show you here the history. We began in 2015 and we had 5 participants. There was the residents working in Moshi at the Regional Dermatology Training Center in Tanzania. And I will tell you a couple of words after about this. And then we continued in 16, 17, and 18 at the same place. And you see, we had more participants, up to 61. Here you see how many pathologists and how many dermatologists. We had several African countries and people from all over the world coming to speak or to listen to the conference. In 2019, we decided to go out of Tanzania and to begin a new series. So every second year we wanted to go out of Tanzania and every second year to be in Tanzania. Why to remain in Tanzania every second year? Because there is a very important conference in January, the Continuous Medical Education Conference organized by the Regional Dermatology Training Center. And this continuous medical education is running since 1992. And it is a very important platform for dermatologists and people interested in tropical medicine and tropical dermatology. So it's a platform where people from Africa, but from all over the world, are coming for 3 or 4 days in January to meet and have a conference. In addition, this conference is very important for the trained dermatologist or ADDV. So this is specialists with an advanced diploma in dermatology, so like nurses or physiotherapists or people from the health system that are not physicians but are trained in dermatology 2 years. So the Regional Dermatology Training Center did a lot of effort training them, and we are organizing the African Dermatopathology Conference as a joint meeting to this CME, and this is the reason because we were 4 years after each other in Moshi. As said, we decided in 2019 to go to Rwanda, and these are the numbers from the Rwanda meeting. And 2020 it was the last time that we had it in Moshi. 21 we did not have any conference, and you see today online we have more than 300 participants. We are growing fast, and the next meeting will probably be a hybrid meeting. I will tell you more later. Here are some countries where the people came from during the last years, and such a conference or such a meeting with a lot of people interested in dermatopathology from different African people and different countries is something that you can organize and you can have only if a lot of people are working together. And the Ujamaa concept is that everything is connected to each other. And this is something that you know from Tanzania. Again, as I said, a lot of people are working together, and there has been some financial support to an African dermatopathology project, a development project of African dermatopathology. And here you see who was behind, I would say, during the last 10-15 years. So you see 2 hospitals in Switzerland, the hospital in Tanzania, and then the International Foundation for Dermatology, the International Society of Dermatology, and the European Academy of Dermatology Venerology. And I'm very thankful to all people supporting this project and that make possible that dermatopathology in Africa is developing. Here is where everything started. You see the residents of dermatology at the Regional Dermatology Training Center that asked me in the early morning hours to train them in dermatopathology. And because I did this training during a couple of years, I decided later to begin with a conference. This is the conference from 2015. You see here an image from the 2016, 2017. All of these were in Moshi at the Regional Training Center. And this is the image in Rwanda, in Kigali, where we had this meeting outside of Moshi. I take this occasion, I will be live again later to thank you for your participation. And I see you in Moshi in Tanzania or online. The conference, this African Dermatopathology Conference, will be on January 9th and 10th, Monday, Tuesday. And the Continuous Medical Education Conference, the other joint meeting, will be from Wednesday to Saturday. So from 11 to 13 in January 23. So see you there. I think now we are ready to listen to Alice Amani with her talk. Go, Alice, with.
Thank you very much, everyone. Hello, it's been a long time after COVID. I am Alice, a dermatologist and dermatopathologist working in Rwanda in South Africa. Happy to discuss with you lichenoid dermatitis. Next, please. Lichenoid dermatitis have almost 22 differential diagnoses, of which whenever you have a case of lichenoid dermatitis, you should first think of lichen planus, lichen planopilaris, keratosis, graft versus host disease, and so on. But for the interest of today, we are going to discuss 9 cases. Next, please. Today's discussion will focus on lichen planus, lupus erythematosus, dermatomyositis, fixed drug eruption, erythema multiforme, toxic epidermonecrolysis, lichenitis, mycosis fungoides, and lichen sclerosis. Our first chapter, the introduction on lichenoid dermatitis. Lichenoid dermatitis are inflammation of the dermo-epidermal junction zone with basal cell damage. In some cases, the junction zone is obscured and cannot be clearly seen from the papillary dermis. Vacuolization of basal cell layer is present, and mainly you can also see apoptotic keratinocyte. Types of lichenoids, they can be band-like lymphohistiocytic infiltrate obscuring dermoepidermal junction. It can also be interfaced with vacuolar degeneration, which has discrete basal cell vacuolization. It can also be mixed. Here we highlight a case of lichenoid cell-rich type with a band-like infiltrate, a classical variant of lichen planus histopathologically. Next. Interface vacuola with cell-poor type, where we have normal stratum cordium, atrophy of epidermis with vacuolar degeneration and melanin pigment in the dermopapilla with very little inflammation. Histopathological classification of lichenoid dermatitis depends on 4 forms, types, and intensity of basal keratinocyte, where it can be vacuolar. The classical type is acute lupus dermatomyositis. It can also be vacuolar plus apoptosis. Classical type will be chronic discoid lupus, drug, and pleva. Confluent cell necrosis, erythema multiforme is one of the commonest, pleva and fixed drug. Type and distribution of inflammation. If inflammation are in a band-like, the classical type is lichen planus. Superficial and deep lupus erythematosus, drug reaction, syphilis could come into differentials. With the majority of folic necrosis, we can also see some fixed drug, lichen planopilaris, when the inflammation goes to hair follicle. If presence of eosinophil, drug reaction should be considered. If plasma cell are present, think of syphilis in differential diagnosis. If presence of giant cell, lichen nitidus. Again, if more neutrophil, think of fixed drug eruption. If the amount of pigment melanin, if it is a lot of pigment melanin, ashy dermatosis should be considered. Diffuse changes, whereby we have a discoid lupus or even focal parakeratosis should be also considered. The next, please. Next. Our first chapter is lichen planus, lichen planus is a chronic skin eruption of a known etiology which has a high prevalence, and we see it in all races, 2 to 4% worldwide. It affects skin, nails, hairs. It has a predilection on fracture area, wrist, and trunk. Wickham's striae is a commonest sign, and when you have it, it is pathognomonic, and a possibility to Koebner phenomena is considered. This is one of our patients with violaceous plaque, papilla lesions on the back in the first picture. Second, here we see the anterior part of the trunk. Again, in another patient, in another view on the anterior part of the trunk. Again, in another patient with sparse papilla lesions on the forehead. Histopathological picture next, please. This was a nice slide where we saw compact hyperkeratosis, hypergranulosis, and a band-like. The band-like interface dermatitis, which is obscuring, was classical for this special case of lichen planus, as we could see it clinically. Next. Again, on higher power view, where we see band-like again, sawtoothed red ridges, and with sparing really the deep dermis. Next. A higher power view, a band-like with really obscuring of dermoepidermal junction and a compact hyperkeratosis, really diffuse lymphohistiocytic infiltrate. Higher power view again showing compact hyperkeratosis, hypergranulosis with sparse apoptotic keratinocyte and a band-like again. The same for lichen planus. We also highlighted here a focal hyperkeratosis, hypergranulosis, and a band-like, really obscuring of basement membrane. Here it can't be seen. So in summary, lichen planus has orthokeratosis, hyperkeratosis, as it is seen here, focal hypergranulosis, irregular acanthosis with soul-to-fed red regions was highlighted in this case. The next chapter to discuss is lupus erythematosus and lichenoid dermatitis. Lupus is a chronic autoimmune skin eruption of unknown etiology, which affect mostly middle-aged women with a predilection on sun-exposed area like face, ears, neck, shoulder. It has a positivity on anti-nuclear antibodies, SSA, and anti-DNA. When possibility to order them, they can help you to make the diagnosis. The cutaneous type usually is a classification of lupus with cutaneous type. Acute lupus will present most of time, more than 90% has systemic signs. Subacute lupus will have only 20 of systemic signs. Chronic discoid will have 5 to 10 systemic signs. Lupus timidus, lupus panniculitis, and tubular lupus. These are the classification on skin. Here we highlight a patient who was a 40 years old female patient with alopecia and thin hair. The picture in the middle highlighting hyperpigmented plaque in the earlobe, on the cheek, scalp, with clear-cut scarring alopecia. Again, in another young man of 40 years with malarash, in another lady with malarash, with alopecia, and last picture in the right side with atrophic patches on the shoulder. Lupus histopathologically has epidermal atrophy. Less commonly, you can have acanthosis, lichenoid inflammation with necrotic keratinocyte, thickening of basement membrane, which can be highlighted well with PAS staining. Pigment incontinence with melanophage are present, then perivascular mixed inflammation. Sometimes plasma cell can be seen with mucin in the dermis to be highlighted with toluidine, but sometimes in H&E you still can see it. Mostly lupus will not have eosinophil. The chronic lupus is characterized by follicular plaguing, hyperkeratosis, and alopecia, as we saw in the other previous pictures. And histopathologically, you have deep and superficial inflammatory process with spot of elastic fibers and mucin. The subacute by itself will have more epidermal atrophy, less hyperkeratosis, more superficial infiltrate, and mucin. Tumidus, no interface, it has a pattern of pseudolymphomatous infiltrate and mucin. For this case, we didn't have pictures of timidus. Subacute lupus erythematosus will have more vacuolar changes, epidermal atrophy, edema, and mucin. Less commonly, you can have hyperkeratosis, follicular atrophy. Sometimes prominent red bodies can be highlighted. Systemic lupus by itself, prominent vacuolar changes, few red bodies, and sometimes neutrophil and fibrinoid material in the dermis. Now, slide pictures for lupus erythematosus, this systemic one. We see normal stratum corneum atrophy and almost flattening of epidermis and some focal vacuolar degeneration. Here again, deep and superficial perivascular and perifollicular lymphohistiocytic infiltrates to higher power view. Next, here again we see a diffuse infiltrate in the papillary dermis with flattening of epidermis. Higher power view with follicular plaguing, the most common in discoid lupus erythematosus, deep and superficial perivascular and perifolicular infiltrate, which is classical pathology for the chronic discoid lupus erythematosus. The same power view of the discoid lupus. Next, please. Again here with mucin on the upper picture and left picture on PAS staining, thickening of basement membrane, and almost always lupus erythematosus will have CD123 positivity in the right lower picture. Here it's highlighted. Next chapter is again deep and superficial infiltrate perifolicular plugging is highlighted in this picture. High power view, seeing the follicular plugging and vacuolar degeneration. Same lupus with focal parakeratosis. This is just to highlight many views of lupus histopathologically. Diffuse inflammation in the papillary dermis, almost with apoptotic keratinocyte in the epidermis. Our third chapter is dermatomyositis. Dermatomyositis is a chronic idiopathic inflammatory skin with myopathy and classical skin presentation, whereby heliotrope rash are classical, Gotron papille, muscle weakness, almost creatinine kinase are elevated, and it can be paraneoplastic in adult, and there is also a juvenile variant. Clinically, it has a symmetrical proximal muscle weakness, and histopathologically, it presents with necrosis of the muscle, biopsy, pathological creatinine kinase and myoglobin serum are present, pathological electromyography, myogram, and dermatomyositis type skin changes as highlighted by Peter in their paper. Next. The first picture, a lady with swollen periorbital edema, erythematous patch, almost patches, swelling, a full swelling of the face. In this picture, we couldn't see also the neck. We could also highlight that even on the neck, the V-neck was having similar rash. And the two other pictures on our right side are carcinosis cutis in a juvenile dermatomyositis. This patient started having dermatomyositis when she was only 11. By now she's 21. She's still having carcinosis cutis. Next. Another variant of, another view of dermatomyositis in an elderly with abdominal patch and thigh patches. Again, Gutron papille on the dorsal hands and also patches on the chest, and somehow the muscle you cannot really highlight it, but the patient was in a position which is relieving her pain. Next, please. With difficulties to elevate. Histopathology of dermatomyositis has almost always atrophy of epidermis. You can only see acanthosis if you take a biopsy of Gutron papille. Another variant of another presentation of dermatomyositis, this would be a vacuolar degeneration of dermoepidermal junction with apoptotic keratinocyte, telangiectasia, and discrete edema of the papillary dermis and mucin. Almost dermatomyositis histopathologically, and systemic lupus cannot be differentiated, or acute lupus erythematosus per se. Next. Dermatopathology description of dermatomyositis, as said before, it has an interface of vacuolar dermatitis with bed bodies. Sometimes neutrophils, fibrinoid material can be seen. It has mild to superficial perivascular infiltrate, usually thickening of basement membrane, as we saw it also in lupus. Sometimes epidermal atrophy is seen with pigment continence and telangiectasia clinically, which are seen as poikiloderma. Next. Here again, we highlight a slide, histopathological view of dermatomyositis with mild vacuolar degeneration, and we can only see the telangiectasia with melanin pigment. Next, this view is not seen, but you can at least appreciate the atrophy of epidermis. Next. Atrophy of epidermis, vacuolar degeneration, and some mucin. Even though we are still on H&E, it is possible to appreciate the mucin. Parakeratosis, atrophy of epidermis with mucin, which is highlighted, and focovacuolar degeneration, sparse perivascular infiltrate. Again, another view with vacuolar degeneration, atrophy of epidermis. If we are lucky, I didn't do the basement, the PAS staining, we could at least appreciate the thickening, even though it is not done. Next, please. Histopathological differential diagnosis of dermatomyositis is mainly systemic lupus erythematosus, and usually you need a clinical pathological correlation to confirm one to another. Of course, S100, CDs 123 is another help to highlight more lupus than dermatomyositis. Consider that there is also an overlap or mixed finding which can be seen. The fourth chapter is fixed drug eruption, which is usually commonly located on the genital, mucosa, hands, feet, intertriginous. There is always a history of drug intake, barbiturate, tetracycline, sulfonamide, non-steroidal anti-inflammatory drug can also be highlighted, but even some other drug can be involved in this. Clinically, they present as round to oval erythematous lesion after use of specific medication. It heals and leaves hyperpigmentation. Usually it can be solitary, but sometimes they are multiple. It can end up with formation of blisters. This is one patient with one big spot on the back and also more on the chest, another one on the axilla, neck, and breast. For this case, it was after brufen intake. The histopathology of fixed drug eruption, it has also a lichenoid pattern as discussed, with a prominent vacuolar degeneration and sphered bodies. Interface obscuring infiltrate as seen as an erythema multiforme and pleva. It has striking pigment incontinence, which can make a differentiation between pleva and erythema multiforme. It can also present neutrophil as opposed to EM. Usually, deeper infiltrates are seen in fixed drug eruption as opposed to erythema multiforme. Next. Here it has intraepidermal blisters with diffuse melanin pigment. Next. Diffuse melanin pigment. So the stratum corneum was quite normal, vacuolar degeneration, but diffuse melanin pigment is seen on higher power view. We also see that the vacuolar degeneration, apoptotic keratinocyte, and diffuse melanin pigment. Again, to highlight this, the diffuse melanin pigment, which is pathognomonic for fixed drug eruption, which is seen clinically as post-inflammatory hyperpigmentation with a nice demarcation. The fifth chapter is erythema multiforme, which has a polymorphic red macular targetoid iris-like lesion on the palms or somewhere else. It can present as papule urticaria. It can also present as vesicle or bulla. Sometimes targetoid lesions are seen. Extremities are more affected, but mucus also are involved. The drug are, even though mentioned as differential, but mainly herpes simplex infection is the most underlying cause of erythema multiforme. In some books, there is this spectrum of erythema multiforme, Steven Johnson to 10. But for Steven and 10, there is this controversy. They are drug, but erythema is due to herpes simplex. So even though they are on a spectrum, it is this controversy. The T-cell mediated immune system is highlighted for erythema multiforme and sometimes idiopathic with microorganisms, and even Mycobacterium have been underlined as a cause of erythema multiforme. This was a patient with pregnancy of 32 weeks who presented erosion on the lips and blisters on her legs and arms. I missed the nice picture on the palms for this particular patient. Surprisingly, when we did the histology, we found it was erythema multiforme. And we gave acyclovir, and the patient improved quite well. Next. Histopathologically, as said, it has necrosis in a part of epidermis. Next, please. We see that there is a necrosis almost halfway of the epidermis presenting with necrosis and vacuolar degeneration in the sparse perivascular infiltrate. Again, vacuolar degeneration, sparse perivascular infiltrate in the papillary dermis. Next, on higher view, we see apoptotic keratinocyte and vacuolar degeneration, sparse perivascular infiltrate. Here again, high power view with perivascular infiltrate and vacuolar degeneration. Few apoptotic keratinocytes are seen. Erythema multiforme pathology differentials are drug reaction, but we've seen that fixed drug eruption will have deep and superficial and have prominent melanin pigment. Viroexanthem can be one of differentials, but it has less apoptotic keratinocyte. Lupus is also considered, but usually it will get involvement of adnexa. Doesn't have eosinophil, but also it has the mucin. It is actually more similar pathologically to pleva and graft versus host disease. The other chapter interesting in underlichenoid is toxic epidermonecrolysis. This is a 13-year-old female patient who presented to us with a chronic CKD, diabetic, hypertensive. She was having a panel of more than 10 medication, vitamin D. She had really a lot of medication for a very long time, and definitely she developed reaction to most likely beta blockers, because we stopped the beta blockers and gave alpha blockers, and our patient improved, even though we missed her because she was having a multi problem in her life. She died, but it was really a patient whom we had difficulty to know which to stop and not to continue, because she had more than 10 medication. Next to her, there is another case of toxic epidermonecrolysis, of which we most of the time in our setup and even in other setup, we have difficulties to have the final drug, culprit drug, because most of patients don't even bring to you the medication they are taking. So finally you can make a diagnosis, but you don't know to advise for the future which medication they should avoid. Next, please. So histopathologically, toxic epidermonecrolysis has full thickness necrosis with even subepidermal blisters, which is not having inflammation. Next. Again here, full thickness necrosis with subepidermal blister, almost no inflammatory cell. High power view, it's the same here. So toxic epidermonecrolysis, it was under lichenoid dermatitis, which is having characteristic full thickness necrosis with blisters. Again, same view. Full thickness necrosis with sparse perivascular infiltrate in the papillary dermis. And please note that the stratum corneum is quite normal, so meaning this is really an acute process. Here again, we have full thickness necrosis with sparse perivascular infiltrate of lymphocyte and some eosinophil as per se. Lichenitis is a common inflammatory skin disease which has more flat-topped papillary lesion. Histopathologically, it can be just inflammation, small inflammation in 2 to 3 dermopapilla with lymphocyte and giant cell and few epithelioid cell. Granulomatous is one of the most common findings to make it differentiating from other lichenoid dermatitis. It will get focal parakeratosis just above the granulomatous reaction, and some discrete vacuolar degeneration can be seen within the membrane zone. Next, histopathologically, here you can see focal parakeratosis, where we see this inflammation just in 1 to 2 dermopapilla. High power view next, please. Again, here we see focal parakeratosis above the granulomatous part, which is involving the 2 papillary dermis with focal vacuolar degeneration. High power view, we also see this prominent parakeratosis, vacuolar degeneration, and granulomatous. A few of them are giant cell seen here. Again, same higher power view highlighting vacuolar degeneration and some giant cell. So in summary, lichen nitidis will have that granulomatous infiltrate lichenoid vacuolar degeneration, which are only focalized in 1 to 2 dermopapilla plus giant cell. It's classical histopathologically if you have clinical correlation to have the diagnosis of that flat-topped and an itchy lichen nitidis. Mycosis fungoides, which is also under lichenoid dermatitis. Here we present a case of a 65 or the elderly patient who had multiple plaque on her trunk with histopathology having hyperkeratosis, some sparse infiltrate in the papillary dermis with some epidermotropism. Next, please, on higher power view. High power view of the previous, we see again perivascular infiltrate with some epidermotropism, which is next better view seen in CD4 staining, and you could see that the epidermotropism was highlighted. The patient was treated with PUVA therapy. She improved. So far, there are no tumor stage. She's still on the stage of patch and plaque. Next, please. Lichen amyloidosis, which is also under lichenoid dermatitis, it has a persistent confluent pruritic papilla and plaque on extremities, which are frequent on the shin, beginning unilaterally, but it can also spread on the other half. I'm sorry I don't have picture for this case. Next, lichen sclerosus. It's also under lichenoid dermatitis, differential diagnosis histopathologically. It's a chronic sclerosing skin disease, which is commonly seen on anogenital region. Rarely, it can also be extragenital. It is very pruritic and almost always no systemic manifestation. It can be overlapping with morphia. So only histopathology could help. Here again, a picture of a patient on the chest and genital. Next, it has also a live. Early lesion could be more lichenoid, while late lesion can look more scar or fibrosing. So early stage, it presents as a compact hyperkeratosis with broad red ridges. Eventually, acanthotic epidermis can be seen with lichenoid lymphohistiocytic infiltrate, sometimes only vacuolization of the basal layer, edema and fibrosis of papillary dermis, or with homogenization is seen. The early stage. For the next, please, the late stage has atrophy of epidermis. Almost always you don't see that perivascular in the papillary dermis inflammation. You could see sclerosis and here lionization of collagen in the papillary dermis with dilatation of capillaries. considering that almost all the time the lesion might be on the genitals where you have many capillaries. Sometimes subepidermal blister can be seen. Here the slide showing homogenization of the papillary dermis with flattening of epidermis. We don't see any red ridges. On higher power view, homogenization of the papillary dermis with flattening of epidermis. This is almost the late stage of lichen sclerosus because we don't see any inflammatory process. Next. Again, on high power view with telangiectasia, homogenization, and flattening of red ridges, and nothing to see on inflammation. This takes me to the end of the presentation. I thank Helmut for, my sincere thanks to Dr. Helmut for his support. I used some of his slides. My sincere thanks to the colleagues and you for attending this session, and thank you. I'm waiting for your question and comment. Thank you very much. Bye.
Hello, everybody again. Thank you a lot, Alice, for this marathon through the lichenoid dermatitis. You explained a lot. I think a lot of our colleague did learn a lot, seeing all the variants of this particular pattern of inflammation. Now we are reaching slowly the end of the conference. We have our last speaker. This is Adane Ayele Lejese from Ethiopia. And he is speaking about some interesting cases. Please, Adane, thank you for your lecture.
Good afternoon all. My name is Adana Ayela. I am a dermatologist and a dermatopathologist practicing at Addis University in Addis Ababa, Ethiopia. In our daily clinical practice, we may face cases that are either rare or cases that have an unusual clinical presentation. Such cases will definitely pose diagnostic difficulty, so additional diagnostic modalities may be needed. I'm going to present you 3 dermatology cases from my hospital, from where I practice, and these cases were difficult to be diagnosed clinically, but histopathology solves the puzzle. I'm sure most of you have come across with many of such instances where dermatopathology gives you all the relief of diagnosing such cases. The first case. The information that I'm going to give you is information collected from the patient before a histologic diagnosis was settled, so the history might be limited. So our first case is a 14 years old male patient who presented to us with an asymptomatic rash that begins over the tip of the right big toe, which expands slowly proximally, and later it brings nail damage. And he has been having this for over a year. He has been repeatedly treated at his locality with unspecified medications, but with no avail. Later comes to our hospital. This is how it looks clinically. It is slightly erythematous, indurated, and scaly plaque lesion. At the tip of the right big toe, a vision from the side of the big toe. The maceration is due to application of a bandage for a longer period by the patient. It's not part of the ongoing clinical problem. The nail damage is clearly visible from this picture, and the subungual extension of the lesion is apparent. So an incisional biopsy was sent to the pathology department with a diagnostic impression of ruling out deep fungal infection. Histopathology shows the following changes. In this scanning magnification, we can see that there is scale crust, and epidermis is hyperplastic to the extent of pseudoepitheliomatous hyperplasia. And you can also see that there is inflammation at the upper dermis. Slightly higher magnification reveals additional finding, which is the dermal finding. The dermal inflammation contains histiocytes, many histiocytes with their eosinophilic cytoplasms, showing or telling us that a form of granulomatous process taking place, in addition to the other changes that we have seen on the scanning magnification. Slightly higher magnification confirms the presence of granulomatous inflammation. Higher magnification reveals these oval-shaped organisms with slightly eosinophilic cytoplasm and a purplish dot in them, arranging themselves at the periphery of the cytoplasm of the macrophages. These organisms are a mastigote stage of Leishmania species known as Leishman-Donovan bodies. With these histologic findings, the diagnosis is settled to be cutaneous leishmaniasis. Why do I present this case? It's because of its unusual clinical presentation. So, leishmaniasis is a protozoal disease which is caused by Leishmania species and which is transmitted by the bite of infected sandflies. Because of the species and host factors, different forms of cutaneous lesions can be seen. In Ethiopia, 99% of cases of cutaneous leishmaniasis is caused by the species Leishmania ethiopica. Leishmania ethiopica is known to bring about localized cutaneous leishmaniasis, diffuse cutaneous leishmaniasis, as well as mucocutaneous leishmaniasis. If a patient presented with typical clinical presentation, which is compatible lesions on exposed areas like on the face, which includes the cheeks, the forehead, the ears, the nose, and on the upper extremities, then the clinical diagnosing it clinically might not be that difficult. especially Leishmania aethiopica tend to be mostly on these exposed areas when compared to other old world species. Some literatures show that facial lesions can reach up to 97.6% of all the cases caused by Leishmania aethiopica. So in such cases where there is a typical clinical presentation, diagnosing it clinically might not be that difficult. It is a very rare occurrence to see cutaneous leishmaniasis on the foot, especially on the toes. In this particular case, in our case, diagnosis was settled by histopathology. Therefore, index of suspicion is very important in such granulomatous lesions, which I can call it leishmaniasis compatible lesions, even if it is happening at an unusual site. My second case is about a 12 years old male patient. He presented with an intensely itchy rash initially, which later becomes largely asymptomatic. He was having this problem for the last 1.5 years. The lesion gradually generalizes and progressively thickens. So the thickening happens to be very marked over the hands, the feet, buttocks, elbows, knees, heels, and over the scalp. And this progressive thickening hinders the daily activity of the patient. We are going to see these areas one by one. On this picture, we can see that there are multiple very scaly and hyperkeratotic crusted plaques over the back of the scalp and back of the neck with fissuring. There are also tiny papules surrounding these plaque lesions, especially at the back of the neck. There are many excoriated papules on the back, and there is very hyperkeratotic and fissured plaque lesion over the right elbow, and there is also an adjacent scaly plaque lesion over the right forearm. Similar lesions are also noticed on both knees, all together with the presence of multiple papules over the thighs and over the lower leg. The exaggerated hyperkeratosis almost looks like a horn, particularly in this position. Similar changes are noticed on both buttocks and at the gluteal cleft, extending to the lower back. Additional finding is the presence of extensive subungual hyperkeratosis, apart from the other changes that we have already seen on other parts of the patient. Similar changes on the soles. Similar changes on the dorsum of the foot, but slightly to a lesser extent, and similar changes on both heels. Again, incisional biopsy was taken and sent with a clinical impression of chronic mucocutaneous candidiasis, keratinization disorder, neglected psoriasis. I think it is sensible to start from the highest magnification. On histology, we found this organism hiding in the stratum corneum. It's oval, having an ectoskeleton and spines, straight muscle, and eggs within it. So this is Sarcoptes scabi. This scanning magnification shows thickened stratum corneum, psoriasiform epidermal hyperplasia, spongiosis, and dermal inflammation. Additionally, there are many scabies mites within the stratum corneum forming burrows. Many mites within the stratum corneum, which we don't usually see in ordinary case of scabies. The dermal inflammation also contains numerous eosinophils. The clinical pathology correlation leads us to the diagnosis of crested scabies, otherwise called Norwegian scabies. Why this case? Because it's unusual and also a rare presentation. So scabies is an infestation caused by an ectoparasite called Sarcoptes scabi variety hominis, and crested scabies is its rare manifestation, which is due to the uncontrolled proliferation of mites within the skin of these patients. Crested scabies can develop in patients who are having defective T-cell immune response, or in patients who are having reduced cutaneous sensation. It's not uncommon to get patients with crested scabies with no identifiable risk factor. The way our patient presented is unusual and rare. 2 months after treatment with systemic ivermectin, topical permethrin, and topical keratolytics, our patient looked like this. My last case, 19 years old female patient who presented with solitary, slightly painful and brownish lesion over the right calf. This was there for the last 2 years, and she noticed drops of fluid on the top of the lesion most of the time. The lesion was brown to dark, ill-defined, nodule. The 2 scars were the site for the previous biopsy, which was not done at our hospital. At this point, the lesion is clearly seen to be hyperhidrotic. This time, external biopsy was done and sent with differentials including dermatofibroma, melanostic nevus, and Kaposi sarcoma. Histopathology reveals scanning magnification shows slightly acanthotic and papillomatous epidermis, and within the deep dermis we can see that there is an increased number of eccrine glands. This is another section from the same biopsy specimen showing the increased number of sweat glands, eccrine sweat glands, and the presence of dilated blood vessels in an increased number in close proximity to the sweat glands. The blood vessels are thin-walled and surrounding hemosiderin deposition is noticed at this magnification. Closer magnification of the thin-walled ectatic blood vessels in an increased number. These evidences help us to reach to a diagnosis of eccrine angiomatous hamartoma. Why this case? Because it's a rare presentation and because it's a benign condition for which aggressive treatment is not needed. So eccrine angiomatous hamartoma is a hamartoma of eccrine and vascular structures. It's an epithelial and mesenchymal proliferative condition. It can be congenital or it can appear later in childhood, but adult presentation is very rare. The two common symptoms of eccrine angiomatous hamartoma are hyperhidrosis and pain. As long as there is no associated symptom, no cosmetic concern or no disfigurement, treatment of this condition is not necessary. But if treatment mandates, then surgical removal is the appropriate choice. So in conclusion, such cases might be straightforward from a histopathology point of view, but still quite challenging from clinical point of view. For dermatopathologists, clinical considerations are not always in line with histological conclusions. Let's open our minds for a different diagnosis not mentioned in the clinical differential diagnosis. And for dermatologists, let us embrace the importance of dermatopathology, which I think is lacking in most countries in Africa, in our daily clinical practice. Thank you very much. Thank you for your attention.
Thank you, Adane, for these 3 very interesting cases. I saw several cases of scabies in my life. I also was part of a big scabies epidemic where we treated more than 1,000 patients, but the patient like the one you presented, I've not seen. Thank you very much. So we are coming to the end of our conference. We have a little bit, we are sooner than the program, and I invite all lecturers to join this room, the lecturer of this day. It's better to have the lecture of this day because there will be only question about today. Unfortunately, in the question online, I've seen only one question from Wayne Grayson to Jason Sluzevich. I have not seen any other questions from the audience. It's strange. Normally in a conference like this, you have several questions, and knowing that more than 300 people are looking, I'm asking myself if something was wrong with the connection of this chat line. I'm waiting that other people are joining the room so that we can discuss. I see Marva and Alice. Hi, both of you. Thank you again for your contribution.
You're welcome, Helmut. Shusho, thank you. Speaking about the chat, I noticed that in the link of the YouTube that I used to watch, I couldn't access the chat, so I had to open it from the DocFlex on my cell phone to post something. So maybe this is a difficulty I faced. I
Okay.
don't know if anyone who.
If most of people were using the YouTube link, then the chat was not so easy to use. I understand.
Yeah.
I'm just reading the question from Wayne Grayson to Jason Sluzevich. We know that Jason will not be online because he is physically in Florida and it's middle in the night. And I know that he will answer with later with an email. The question was, there is a known association between inflammatory EBA and SLE. Do you have any useful pointers that might facilitate distinction between bullous SLE, lupus, and neutrophil-rich inflammatory EBA? As the former would also reveal a neutrophil-rich subepidermal blister on biopsy. So the question if there is a chance to make a differential diagnosis or to differentiate the lupus from the neutrophil-rich inflammatory epidermolysis bullosa, because both may have the neutrophils. Myself, I don't have a question for this, an answer for this question. Adane, I have a question. We are already here. I see you. Now you disappeared, Adane. Maybe you are listening. I have a question of your second case, the case of scabies. Maybe I've not heard well. I've seen the presentation and I've seen that you treated the patient and he ended up very, very well. Do you know how many people were? Do you know how many people has been contagious by this patient? Do you know something? I'm waiting that you are coming in the room. Maybe waiting, Adane. I take the chance to greet all of you, and now especially I'm going to Wayne Grayson. Thank you for your lecture. You already highlighted a lot of clues, but maybe you can summarize to fill this discussion. What are the most important clues where you have skin and you suppose you think it could be something infectious? What are the clues that you'd pay attention? Like, of course, like the neutrophil in stratum corneum, this special sign of Ackermann. But let's speak about some dermal signs. You mentioned it in your lecture, but repetition helps. So can you say 2 or 3 things that you look at, particularly when you are suspecting something infectious?
Thanks, Helmut. That's a broad question, but I think for all of us who practice pathology on the African continent, I think it may sound simplistic saying this, but one should automatically have a high index of suspicion. So I think that's the way I approach it. So if I see inflammatory things, I think infection first, and but because once I think you see, it depends where one practices in the world. You fine tune your diagnostic acumen to what's prevalent around you, and if you're working in a country where there's a high prevalence of HIV/AIDS, for example, you automatically are alert to that. So I think a high index of suspicion is always an important thing to have. So that's where I start from usually.
I have a particular question about your sausages that you are describing when this thick inflammation, mostly of histiocytes, but also of lymphocytes. I'm not sure. I'm just asking you. When you see this pattern, you see how frequent you can confirm that there is an infection.
Well, I
It's a
think it's
difficult question.
It is a difficult question. The term sausage, I wish it were something that I dreamt up. But if I'm not mistaken, I think it may have been Ramam
Yes.
who in New Delhi who coined that term, and I think it's a
It
great
is.
description because it's such a distinctive low power look that I think one must automatically think of leprosy, and it's not just a perivascular infiltrate; it really does follow the neurovascular bundles, and the more you look at the deeper sections, you can appreciate how it's insinuating along them. Other things can look similar in a way. I'm just thinking outside of infectious diseases where I've seen leukemic infiltrates do something similar, but they also tend to show more of a proclivity for being around the ecrine coils and maybe pushing the ecrine glands apart. So it's not purely a neurovascular thing. I've also seen recently, Torello had a case of erythema nodosum leprosum as a manifestation of iris in a patient who'd become resistant to the antiretroviral treatment and then had the regimen changed and then flared like that. And even the dermis in that case looked like that, even despite the presence of very extensive subcutaneous involvement. So I think that's a very important clue for leprosy. Sometimes, particularly when one's not dealing with sort of polar cases and you're more in the borderline group, and it's sometimes not as clear cut as one might think. And also, if patients have been partly treated, sometimes the way it fights stains not always that helpful because it's staining up the lipid content of the walls of the bacteria. So once they start to break down, the stain doesn't seem to work well. But something that I learned from Philip McKee many years ago was to do a stain for nerves, like an S100 protein, or these days we can even try SOX10. And it's remarkable how you see the nerve destruction within those neurovascular bundles, and that's a real red light for leprosy. So, we don't see it all that often anymore in our country. But, I work in a private laboratory, and we've seen, I think, 2 cases this year. And I think it's because it's not taught that well in medical schools. In the community, people don't see much of it. Things are misdiagnosed and the patients go from doctor to doctor without anyone having done a biopsy, or a wrong diagnosis is rendered. I remember a few years ago, I saw a biopsy from a 15-year-old girl who'd been, was diagnosed as, I think, a sarcoid at one stage and vitiligo on another occasion. And she had tuberculoid leprosy. So I think everything revolves around a high index of suspicion. I don't know if that answers your question, Helmut.
Yes, of course. Thank you. Thank you very much for your answer. Do you have here in this chat room, in this discussion room, other people has questions? I have two other questions if you haven't. Adane, maybe you didn't listen. You couldn't listen before. Maybe I repeat my question. Do you know in your scabies patient how many people get scabies from that patient? Do you have an idea how many get contagious?
Hello, Dr. Helmut. Can you hear me?
Yes, I hear. Everybody hears you.
Hello, everyone. First of all, thank you very much for bringing us together like this every year. Yeah, it's a great achievement. And for your question specifically, I can't answer you directly. What the information that I gathered is information that was there before the diagnosis of scabies was histopathologically confirmed.
Yeah.
So
Okay.
I remember that all the parents were given treatment, and even those clinicians who were attending this patient were afraid of catching it because
I would also.
Yeah, after the diagnosis of crested scabies was made on the histopathology, but luckily I hope no one was there, because crested scabies is it's very, very contagious, and mites can reach up to 1 million. So yeah, that's
as I mentioned before, we had a case of crested scabies in our hospital, and we reached to treat 1,600 people. Not everybody was infected, but it was also preventive measure.
Yeah, you're right.
I have a question to you, people working in Africa. how frequent, or do you have today the possibility to stain immunohistochemistry, or only few stains, or not at all? How is the situation today? How much immunohistochemistry? Maybe I begin like a clock. Marva, how much immunohistochemistry do you have? We don't hear you.
Sorry.
Can you? Yeah.
Yes. My cases, one of them was the extra memory Paget. So this was before the pandemic. We had a lot of immunohistochemical stains available. Today, we have financial issues, and exportation is like a little bit suspended. So
Okay.
we have a lot of troubles with the immunohistochemistry. We are back to the more depending on hematoxylin and ACE sections to diagnose.
So you do more than 95% of diagnosis, or even 98
Yes.
all by H&E?
Yes, unfortunately, yes.
Can I ask you, Alice, how is the situation in the pathology department in Kigali? Maybe I go to Adane and I let Alice answer after. There seems to be a technical
thank you.
problem.
So far,
okay.
we have many for cancers.
Alice.
Yeah.
Do you have some for cancers? Connection is not
getting
good.
me?
Yes, now yes.
Yes. Okay, so currently we have for most of cancers, we have them, or all of them we have, only we don't have HHV8, and at least we have improved so far. Yeah,
So
we have more than 10.
When you need it, you can use it. When you need it, you can use it.
Yes.
Also for lymphoma?
And it is covered by insurance. Yes, for lymphoma, yes.
Oh, it's a great news.
But phenotyping, not of course. We have the CD20, CD20, CD3, 8, 31, 34, CK7 and 20, even others. You have a bit. Yeah.
Okay. And what about the situation in Ethiopia, Dane? We don't hear you.
Sorry, the situation in Ethiopia, I can say, is the worst because we don't totally have an AHC service at all. So we rely ourselves on the basics, the hematology and the H&E staining, eosin staining, and some special stains are available. Otherwise, we don't have the IHC at all.
Thank you. And Wayne, I can imagine in South Africa you have a better situation, probably.
Yeah, it's humbling to hear how many of one's colleagues struggle on this continent. We really are spoilt here. I mean, even in the state sector, the National Health Laboratory Service in Johannesburg has a very comprehensive panel. And if a given lab doesn't have that particular antibody, it can always be referred to another laboratory. We're also spoilt in private practice because the healthcare funders do fund the stains. So we don't have everything. But we certainly have a lot. But I think it's true to say that in our line of work, apart from the cancers, most of what we do, we can get away with a good H&E and some of the basic histochemical stains, I think. So it is depressing if one works without the luxury of immunohistochemistry, but I think one can get very far without it. Mm-hmm. And if you fine-tune your diagnostic acumen and just rely on morphology and observation, you can get very far. I think it's where the problem comes in with hematolymphoid neoplasms and undifferentiated high-grade malignancies. Then it becomes a real problem. But I must say we are spoilt in South Africa.
I had the question to Luli, but now she disappeared from the screen. Maybe Luli, you can re-enter. My question is, how is the situation now in Moshi? When I was working there 15 years ago, there was no immunostain. How is the situation today, Luli? May I ask you?
Hello, everyone. Can you hear me?
Yes, we hear you. Very good.
Okay. Nice to see all of you. At the moment, we have a CD30, CD3, and CD8 for lymphomas, and these tests are done at the general pathology laboratory.
Yes.
It costs about 50 USD per staining, so it is relatively expensive for our patients. So just like my colleagues, we rely on H&E on most of the cases, but sometimes when necessary, then we have to order them, and we have social funds for special cases.
Okay. Thank you.
Yeah.
Thank you, Luli. And how many colleagues are working now in the pathology department in Moshi?
For dermatopathology, it's only me.
Yes.
But I have a good number of colleagues in general pathology.
Okay.
About 5, I think,
5
so far.
This is a good improvement in the situation in the hospital. Very good.
Yes, yes. Yeah.
Thank you,
But
Luli.
also,
Yes.
there are special stains, immunohistochemistry, that is sent to private laboratory,
Okay.
sometimes to Nairobi and sometimes to South Africa, especially for the adenocarcinomas.
Yes.
Yeah.
Do you have a special deal with? Do you have a special deal with that hospital, or who is paying for these cases?
The patients have to shoulder the costs.
Okay.
Yeah.
I have a question. If you have question, please jump in the discussion. I have a question for Marcus. We in Europe, we have slowly increasing cases of leishmania. And I never saw leishmania 10, 15 years ago in Europe. And now we see regularly every second month one case from southern France, southern Spain or Italy. Have you seen something, Marcus, in Netherlands, leishmania?
Yeah, we see it quite often already for a long period, because we have a lot of people from Suriname and French Guiana.
Okay.
So we do see a lot of patients from there.
Yes.
You are right that indeed from France and from Spain, Ibiza and so on, there are more people coming indeed. So I also have the impression that it's increasing. And I don't know why, if it's more travel behavior, I don't think so. But maybe I think it's a rise of epidemiology, I think.
I can imagine, yes.
Yeah.
Do you have questions?
Yeah, I do have a question for Luli, but I think she disappeared again.
Maybe try, and she's coming again, yes.
I'm here.
Yeah, good,
Yeah.
Luli. Hi. I was wondering, you said that in albinos there are melanomas. Do you have an explanation for that?
I'm sorry, I didn't catch you.
Yeah,
Can you please repeat your question?
In people with albinism, there are not so many melanomas.
Mm-hmm.
Do you know what is the reason for that?
Well, that's a really good question. So far, from the publications I've attempted to read, they are saying that maybe we are missing them during the outreach clinics or when they come for screening, because most of them are melanotic. However, I have not personally seen any patients that are succumbing to any sequelas of any form of melanoma coming to the hospital with mets of that. Most of the time it's squamous cell carcinoma that infiltrates the brain and things like this, but not really melanoma. This one was our very first case to see, and it was quite unfortunate that it was quite advanced to that stage. Our surgical team, as well as the dermatosurgeons, tried to remove as much as possible and then send her to the oncology center. But even that, it's more of palliative care.
Yeah.
Yeah.
May I say something?
Yes,
Now, that's a very interesting observation that you've made. Our former head of department in Johannesburg, the man who gave me a job in pathology, was Charles Isaacson. He passed away a few years ago in his mid-80s, but in the 60s, he made a career of studying just the spectrum of African pathology. And he told me something not shortly before his retirement, and it was an observation which I found quite staggering. He said, and in all of his years in pathology, he had never seen a melanoma in a patient with albinism, which I found quite staggering. You know, when one reads the books and articles, it always mentions that there's an increased risk for melanoma. I must say, I don't think I've ever seen a case. I think I've seen one possible case, but it was so dedifferentiated that it didn't express melanocytic markers. But it is an interesting thing. One just wonders if the patients don't develop the other tumors just much, you know, they develop their squamous carcinomas and BCCs far more rapidly than melanoma. But it is it's a curious anomaly. I wonder what other people feel about that.
We did a research together with Samson Kiprono and Daniel Zuriel, one pathologist and one dermatopathologist from Kenya a couple of years ago, and we were looking at all the cases in the regional dermatology training center. So all cancer, I think we checked 10 years, all cancer in person with albinism during 10 years, and we found a lot of squamous cell carcinoma, more squamous cell carcinoma than basal cell carcinoma. So this is again something different from the Caucasian skin. And if I remember, we found no melanoma or one melanoma. I think no melanoma at all in that research. There are other questions among you.
I'm sure there's a PhD in there for someone, isn't there? If you can answer that question.
Yeah, or maybe, yeah.
Or a Nobel Prize.
Yeah. It's a research to be done. Other questions?
Helmut, I don't know if we can open my question to the floor, and the one I directed to Jason. I know it's a difficult one, and I appreciate your view on the topic too. I asked that question because I was sent a case in consultation from a colleague at the state, working in the state hospital in Botswana, and because of issues with payment, we couldn't really process any specimens in South Africa for immunofluorescence, and we had quite a dilemma. I don't know if the other folks saw the question, or I can repeat it.
I read it before, but you repeat the question so we hear it from you.
Yeah, I just was interested to know if anyone has any advice as to how to discriminate between epidermolysis bullosa acquisita in a patient with SLE and bullous SLE, because there's an increased risk for epidermolysis bullosa acquisita in patients with lupus. And the problem is on biopsy that both of those conditions histologically demonstrate a neutrophil-rich subepidermal blister.
If I understand you, you mean the patient has lupus, so this is given.
Yes,
and
given,
this lupus patient could have additionally an EBA. Eh?
That's right.
Question.
Yeah, and the biopsy showed a neutrophil-rich subepidermal blister. There was an element of scarring as well, I think, and that's why that possibility came up. So that's really why I asked the question, just from a pathologist point of view. But maybe I'm out of line because I'm not a dermatologist. But does it? I suppose the other side of the question: does it really make a difference? Would they not be treated with dapsone anyway and respond? So is it just an academic question rather than a practical one? So I'll just be interested to know people's views on the subject and seek some guidance from you. So thanks very much.
Personally, I understand fully the dilemma. I am not sure. I don't have an answer, and probably you will treat the patient similarly, but I never encountered a case. I don't know if the treatment would work as well. So I find an interesting situation, but I don't have a suggestion how to deal with it.
Yeah, I was just curious to know if split skin immunofluorescence might be useful, but I don't think so, because I think you'd find similar features in both conditions.
I know what happens with epidermolysis bullosa, but I'm not sure what happens with the split skin in lupus. So this could be the answer, but I have to ask as an expert. I don't know the answer.
And whoever looks at split skin in lupus cases, anyway,
Exactly.
who has
But
experience.
probably there is research about it. I will check. Yes.
Yeah, there's
Thank
nothing
you.
new under the sun, but it was quite a dilemma for me, and I felt that I hit a diagnostic brick wall. Thank you.
Are there other questions in the room? I've seen the chat again. There are no additional questions. Fuad, I see you. Hi. Do we have questions, Fuad?
No, I just want to comment on Adana's response. There are recent changes in the country in terms of immunochemistry. There is a private lab called Onco Lab, and they are taking the lead, and they are doing limited number of immunohistochemistries. And there is also one teaching hospital called St. Paul Hospital Millennium Medical College, which runs a residency program for many disciplines. And they are now negotiating with big companies to have a placement agreement to get the machines, but to also be committed to purchase a certain number of amount of reagents per specific period of time. So this is the current situation.
So there is an improving situation.
Yes.
Thank you for this update. Are there other questions, other comments before we close the meeting? So I say thank you a lot for being here. Thank you to all lecturers for the beautiful 2-day presentations. We filled up a very interesting program. I feel sorry, and I do apologize again for the first day. We had a technical problem that was bigger of us. We couldn't solve it within a few minutes or hour. So all lectures, the whole conference will be possible to be seen as a video from next week, not from tomorrow, probably not Monday, but from next week. And all registered person will have the chance to see all lectures until end of the year. So until end of the year, you can look again and again lectures if you want to learn something. And from end of the year or from 23, the lecture will disappear from the online page. Again, I tell you, there will be an 8th African Dermatopathology Conference in Moshi, physically, in person, and additionally online on Monday, Tuesday, 9th and 10th of January 23. This is our next conference. Thank you to everybody. Thank you to all lecturers. Thank you to DocFlix for being a good partner showing the whole conference. Thank you to Vivian Lauper, who assisted here administrative work. And see you next time. See you in January in Moshi. I thank you also to all the 300 people looking the conference from different African countries and possibly from other countries out of Africa. I don't have the list in this moment. I cannot see where are the people from. I will give you a feedback with an email to all participants in the next days. See you next time. Have a nice evening.